Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections. Acne is one of the most common disorders treated by dermatologists and other healthcare providers, with more than 90% of the world's population being affected by acne at some point of their life. Acne vulgaris, or simply acne, is a common disorder affecting the sebaceous follicles with several factors that influence its development. Since its treatment would require antibacterial action, antibiotic resistance is an issue to consider. In dealing with acne vulgaris and other bacterial infections such as impetigo, carbuncles, and furuncles, entrust your patient's skin to effective treatment with less worries about resistance with Nadixa. Nadixa is nadifloxacin, the first topical quinolone indicated for acne vulgaris and bacterial skin infections. It has a broad-spectrum antimicrobial activity that works mainly by inhibiting DNA gyrase, which then prevents bacterial activity and causes cell death. With this mechanism of action, there is a very low resistance compared to macrolides and lincosamides. It also inhibits the production of pro-inflammatory cytokines and suppresses androgen reception transcription activity to 29.8%, giving it anti-inflammatory and anti-androgenic activity on top of its antibacterial activity. Nadifloxacin has been proven to be effective compared to placebo in several studies and was shown to have similar efficacy to erythromycin in reducing acne lesions with no resistance generation in 12 weeks. When used in combination with adapalene, nadifloxacin showed a higher and earlier reduction in inflammatory lesions. It also showed significantly less erythema and less proportion of dryness compared with adapalene monotherapy. In terms of safety, the general tolerance of topical nadifloxacin treatment was rated good or very good by 98% of investigators and 96.6% of patients. In combinations, nadifloxacin does not lead to substantial reactions versus drugs alone. Nadixa is available in 10 mg per gram 1% aqueous cream solution. Nadixa offers strong broad-spectrum antimicrobial activity, low resistance rate, additional anti-inflammatory and anti-androgenic effects, overall efficacy in monotherapy, and in combination with other anti-acne agents, an excellent tolerability profile. Cross out bacteria with Nadixa. New antibiotic treatment for acne vulgaris and skin bacterial infections.
behalf of the University of the Philippines College of Medicine, Postgraduate Institute of Medicine, in partnership with the University of the Philippines Medical Alumni Society, spearheaded by its Davao chapter, we welcome you to Day 3 of the UP College of Medicine Grand Scientific Symposium 2021. I am Dr. Jessa Protasio, and I will be your host for today.
We start this day with a gesture of gratitude. Here is Dr. Maria Pasita S. Belisario, Awards and Certificates Committee Chair, to present our special award.
Sa inyong tanan. We are nearing the end of this 3-day Grand Scientific Symposium. From September 2019 till today, our chapter has been blessed with key leaders who truly guided us along the way. The officers and various chairs of the organizing committee of the UPMAS Davao region nominated and selected awardees who served as mentors and inspirations for our Davao community. It is with great pleasure for me to present the first Magani Award on behalf of our UPMAS Davao region. Magani is a warrior class of the Bagobo tribe. This tribe is said to be one of the most intelligent natives of southern Mindanao. Magani includes a community leader who is usually the Datu, said to be the Chief Magani. This title is given to a person who is held in high esteem with a major role of serving as chief arbiter, judge, and defender of the tribe. This award is given to Dr. Charlotte M. Chong, our very own beloved Dean, Dr. Lilibeth S. Genuino, Executive Director of UPMAS, Dr. Jean Ann B. Toral, 2019 UPMAS President, and Dr. Teresa Luisa G. Cruz, UPCM PGIM Director, for their excellent leadership, commitment, dedication, and invaluable support in the pursuance of the vision and goals of the UPMAS Davao region, given this 23rd day of September 2021, signed by Dr. Assumpta Cecilia Serrano, President UP Medical Society Davao Region and overall Chair of the Organizing Committee, and yours truly, Dr. Pasita Belisario, Chairman, Awards Committee. Thank you, our dear Chief Maganis.
Well, I'd like to, on behalf of the Magani awardees, I'd like to thank very much the organizers of this GSS, led by Dr. Bibit or Dr. Maria Assumpta Serrano, and of course the chair of the awards committee, Dr. Pachot Belisario. I also would like to thank all the dedicated members of the first ever UPMAS chapter of Davao for the awards given to us. They were completely unexpected, but really truly appreciated. And I would just like to say that these awards will be awards that we will cherish as we look back at how the 22nd edition of the Grand Scientific Symposium unfolded. The tradition of the GSS will continue to live on, and because of what the UPMAS Davao chapter has done to make this 2021 GSS as the most successful and the best attended GSS, you really have made history. The UPMAS Davao chapter must have been born only for one reason: your love for your alma mater. How you are alumni there in Davao and the dedicated faculty here in Manila all collaborated in pursuit of the universal healthcare, the fight against COVID-19, the sharing of all the evolving trends in quality and relevant care to cover the most common causes of morbidity and mortality in the context of the needs of particular communities there in Mindanao. It's really a way by which we should model our healthcare in the future. A healthcare that's affordable, accessible, and equitable as a new pathway by which we would be able to see a new era of healthcare in our country. Kung lahat po tayo ay tutulong, mangyayari po ang universal healthcare. ang kalusugang pangkalahatan para sa ating bayan. Matatapos din po ang pandemyang ito kung sama-sama tayong susunod sa health protocols. Maraming salamat po sa lahat na nag-organisa itong Grand Scientific Symposium, sa mga nagbigay ng mga lecture, sa mga nag-moderate, at sa lahat ng mga tumulong na tao, sa Raxo na nagtumulong sa atin upang magandang ating pag-deliver nito, at mga sponsors na sumuporta po sa lahat sa ating, at pati na ang ating mga attendees na hanggang ngayon ay kasama pa rin natin mula nung unang araw hanggang ngayon sa huling araw. Maraming salamat po sa ngalan ng Kolehiyo ng Medisina ng Universidad ng Pilipinas. Kami po ay magbabalik tanaw dito sa GSS na ginanap natin ngayong araw na ito, na isang napakagandang halimbawa ng pagmamahal sa ating kolehiyo at sa ating mga kababayan. Maraming salamat.
We will now begin with Focus Session 4, which will be on aging. The chair of the session is Dr. Carol Pacholes Flavier, and her co-chair is Dr. Annette Boquiren.
Good afternoon, everyone. As we all know, aging is unavoidable, and each one of us will undergo either menopause or andropause, whether we like it or not. This session focuses on both from the points of view of a urologist and an OB-gynecologist.
We start this third-day symposium with a he said, she said type of lecture with the following objectives. So now let's check out what the popular social media app TikTok says about our topic.
Okay, a lot of men are going to hate me for this, but some of y'all need to hear it. Men hot flashes are real. And if you're getting hot flashes, here's the reason. We all started as female, so it's not surprising that we get hot flashes like women. It's called andropause or menopause. And it sucks. It's like you're sitting at your chair one day and it's like the Human Torch, flame on. After the age of 30, men lose their testosterone at about 3% a year. So by the age of 50, you've lost about 60% of your testosterone. And if you're not careful and you gain a little weight, you start producing more estrogen, which means you get a belly and you get man boobs. So it's important to stay in shape. Now, going to your local GNC and buying some kind of testosterone booster will never work. You have to go to the doctor. So ladies, if your man is not chasing you around the house, he may have low T. So get him checked out.
I'm 50, and I think I'm going through menopause. So if you're a guy, you may want to keep scrolling. It wasn't enough that I spent every month for the last 35 years shedding the lining of my uterus, and when I had each of my 3 kids, it was like pushing a Buick through a garden hose. I think, ooh, menopause, you're not going to get a period every month. No one tells you is when you don't get a period, it's almost like having PMS all the time. Then poof, your period shows up out of nowhere. My skin is drier than a pancake without syrup. I used to really feel like I'd knock out my workouts, but now I feel like I'm moving slower than molasses dripping in January. I'm all of a sudden clumsier than a bull in a china shop. I'm bloated like a drowned pig. I used to have really nice, thick, full hair, but no, not anymore. I'm bolder than a peeled egg. We didn't even get to hot flashes. I used to think that was just, I'm hot, I'll take off my sweater, I'll feel cooler. No, it starts at your feet and comes all the way up through your head till you feel like you're gonna explode. You feel like you're living in a jalapeno's armpit. Then you start sweating like a horse in heat. And then when that's done, you start freezing again.
I am pleased to introduce the speakers for this session entitled He Said, She Said, Current Concepts in Andropause and Menopause. Our first speaker is Dr. Dennis P. Serrano, who obtained his medical degree from the UP College of Medicine in 1989. He finished his residency training in general urology at the Philippine General Hospital in 1994 and his fellowship in urology renal transplantation at the Cleveland Clinic Foundation in 1996. He currently has the designation of Associate Professor 7 at the UP College of Medicine, is the Chief of the Division of Organ Transplantation at the UP Philippine General Hospital, and Vice President and Assistant Chief Medical Officer of St. Luke's Medical Center, Global City. Our second speaker is Dr. Angela G. Sison Aguilar from the UP College of Medicine, class of 1991. She did her residency training in general obstetrics and gynecology from 1994 to 1997 and her fellowship in reproductive endocrinology and infertility from 1999 to 2000 at the Philippine General Hospital. She currently holds the designation of Professor II at the Section of Reproductive Endocrinology and Infertility of the Department of Obstetrics and Gynecology of the UPPGH. This session will be moderated by Dr. Karen Lee P. Alabado, a dermatologist practicing in Davao City, and Dr. Jasmine Therese B. Arcilia, Project Associate for the Minimum Initial Service Package for Sexual and Reproductive Health in Emergencies Program, Zweelig Family Foundation, and Dr. To the Barrio, Batch 36.
Let's go to our first question for Dr. Serrano. Do men also experience menopause?
Thank you for that question, Karen. We know this for a fact, and this was established by Michael Brower in a study. Beginning 30 years of age, testosterone production in men decreased by around 1% annually. So if you think about it, by the age of 50, there would have been at least a 20% reduction or more in the total testosterone production of these men. So invariably, all men, as they age, will have a lowering of their testosterone levels. But the incidence of andropause is very, very variable. Not all men get it. No, if you are somewhere between 40 to 49 years of age, the incidence is very low. It's 2 to 5%. At 50 to 59, it's around 6 to 30%. And then consequently, at 60s and 70s, the risks are around 50% to as high as 70%. So in varying stages of life, not all men get it. And there are factors that may aggravate or that may cause men to have an earlier onset of andropause. And really, this is poor lifestyle, lack of exercise, smoking, excessive alcohol intake, stress and anxiety, and of course, sleep deprivation. So all of these factors, put together can herald an earlier onset of andropause among men. Men who generally, try to remain fit even in their elderly state will have lesser andropausic symptoms. So I hope that answers your question.
For the first question for Dr. Aguilar, what age do we expect menopause and its symptoms to start?
In the Philippines, the first known paper to have described menopausal symptoms in Filipino women was that of Julita Ramos Albuenas, published in 1994. In this paper, the average age of menopause during that time was from 47 to 48 years of age. Nowadays, there is an observed demographic shift in large population cohorts towards a later age range. Nowadays, the average age of menopause seems to be between the age of 50 to 52.
Next question for Dr. Serrano. Do men become more irritable and experience mood swings during andropause?
So this is interesting, Karen. Apparently, mood swings or irritability is not just the domain of women who are becoming elderly. It also happens among men. And it is also correlated with their low levels of testosterone. So mood changes, reduction in cognitive function, memory loss, all of these are correlated with low testosterone. On top of that, there's also other signs and symptoms of low testosterone, like decrease in lean body mass, decrease in the muscle mass of these men. Consequently, there's an increase in their fat mass. And you will see that's why many elderly men are also chubby. Consequently, there's a reduction in their energy and their muscle strength, a reduction in their libido and in their erections, and physiologically we also see increased osteoporosis in these men and a reduction in their red blood cell production. There is a direct correlation of all of this to their testosterone levels, and you will see that depression. If we look at testosterone levels that are low, depression together with type 2 diabetes mellitus has an onset when their testosterone levels fall around 10 nanomoles per liter or lower. And usually the normal is around 15 nanomoles per liter. So there is a direct correlation of low testosterone, depression, and all of these other symptomatic correlates in these andropausic men.
For Dr. Aguilar, is being more irritable one of the signs that a woman is approaching menopause?
Thank you, Dr. Jasmine. Women suffer from a constellation of symptoms, not just irritability. So itchy, bitchy, sweaty, and bloated are common, as in this cartoon showing the quote-unquote 7 dwarfs of menopause. The last 3 pertains to symptoms involving psychosocial functions such as sleepiness, forgetfulness, and pardon the term, psycho. So in a presentation by UP Professor Emeritus Florante Gonzaga in 2003, the most common symptoms of menopause in our local setting are hot flashes, irritability, nervousness, palpitations, headaches, night sweats, and dizziness. So remember the 7 dwarfs? There you are, itchy bitchy, sweaty, and bloaty. Not all women report symptoms like the 7 dwarfs that we saw, right? So while they may affect 70 to 80% of women, only 25% of women describe theirs as severe. Severe enough to have half of them admit that they have a significant impact in their home life, and about a third having a great impact in their social lives.
Next question for Dr. Serrano. Why does vitality or sex drive decrease during andropause?
For that question, Karen, let me go back to my previous table, looking at correlates of testosterone level with symptomatology. And again, you will see that there's a linear correlation to lowered testosterone levels and vigor and vitality. Very minor reductions in testosterone. Some men will already complain of diminished vigor. A little bit more reduction down to 11. There's already reduction in the frequency of their nocturnal erections. We already discussed depression at 10 nanomoles per liter, and at 8 and below, there is already the onset of erectile dysfunction. Although I suspect that more men will have erectile dysfunction earlier, even at a little bit higher levels of testosterone, and then really loss of libido at 8 and below nanomoles per liter of testosterone. So it is not just loss of vigor and vitality and erection. There are other symptoms of andropause that are also correlated with the 7 dwarfs of that Angge has mentioned. We've discussed depression. Men also experience hot flashes during andropause. We already talked about obesity. Other symptoms are dry and thin skin, loss of muscle mass, of course, excessive sweating like in women, and finally, erectile dysfunction. So these are all correlates, and these are all linearly related to the level of testosterone that these men have.
The next question for Dr. Aguilar is a decrease in libido or sex drive commonly seen in menopausal women.
So thank you for that question, Dr. Jasmine. There's an interesting finding in a trial conducted on interventions in menopause. They're MS-FLASH trials, and it was found that antidepressants and cognitive behavioral therapy were effective for improving sexual domain scores while it was improving insomnia. So this may lead one to consider that sexual function is not merely an issue of physical discomfort from intercourse. They may also have psychosocial roots as well. And we have to change the way we view sexuality in the menopause. That means that we have to overcome the barriers we have imposed upon ourselves, be it cultural or religious, and talk about sexuality. And when I say we, I mean we as a community, not just our patients, but also us as medical practitioners. And the least frequent group of symptoms during the menopause are the last to emerge, and these are your genitourinary symptoms. While there is a decline in the frequency of sexual activity, surprisingly, as in this paper, It may not at all be related to the physical symptom of vaginal dryness or dyspareunia or otherwise known as painful intercourse. Likewise, incontinence, another symptom, may emerge in midlife that may not be related to hormonal decline. So a decrease in sexual functioning may actually precede menopause. And some groups, such as in Asians, specifically among the Japanese, they may actually show larger declines compared with other races earlier on in their middle life.
For Dr. Serrano, why is it harder to lose body fat and build muscles during andropause?
So Karen, contrary to popular belief, it is not just testosterone is not just useful for sex and libido. No, there are other functions of testosterone, and men who are in bodybuilding or men who are trying to build muscle are notoriously known for using exogenous testosterone to sort of quote unquote beef up their efforts. The reason for this is being really testosterone is responsible for the release of many neurotransmitters that are responsible for tissue and muscle growth. Consequently, it is also responsible for increasing the levels of growth hormone secretion in our system. And metabolically, testosterone helps burn fat more efficiently. So that's why low levels of testosterone in the elderly male translates to less muscle mass and more fat mass. Unfortunately, that is the bane of becoming older among men. The belly becomes bigger, you lose more muscle, you have less strength, and really the detrimental effects of androgen deficiency in the overall male health. It's not just in the detrimental effects on looks. There's a significant reduction in their quality of life, not just from sexual dysfunction, but also really for the risk of mortality because of the comorbidities brought about by low testosterone. And this stem from metabolic to other musculoskeletal complications. And one thing I'd like to emphasize really is the recognition of metabolic syndrome in elderly men. And metabolic syndrome really is a cluster of risk factors for developing coronary heart disease, stroke, and type 2 diabetes mellitus. The factors that contribute or the factors that are essential for the diagnosis or for the cognizance of metabolic syndrome really are abdominal obesity or getting fat in the middle, dyslipidemia, specifically increase in the triglycerides and reduction in the HDL-C fractions in these men, hypertension, elevated fasting blood sugar or insulin resistance. So all of these factors really lead to a worsening outcomes in men in terms of longevity and then quality of life. So not just sex, not just muscle mass, not just fat mass, metabolic syndrome really has to be taken care of in elderly men, especially in andropausic males.
For Dr. Aguilar, why do women gain weight during menopause?
So at this point, I would like to second Dr. Dennis' concerns about metabolic syndrome and other comorbidities among those who are aging. If the woman had her menopause early, that is below the age of 45, then the odds of comorbid conditions are quite high. It is best that we screen for these conditions to prevent serious sequelae from diminishing the quality of life of these women in their advanced years. So do women gain weight during menopause? Not just during menopause, but earlier if their lifestyle predisposes them to have BMI higher than what is ideal. That's why we have to make sure that earlier on, fetal imprinting, childhood, adolescent, and during the reproductive life, we have to continuously export women, all people, all individuals for that matter, to maintain an ideal BMI. And during menopause, they would say that higher androgens, because the balance is tipped towards higher androgens in the perimenopause, may increase the adiposity of women, especially around the middle. And that may be what they would term as quote unquote gaining weight. But lifestyle would really predispose them to this weight gain earlier on, even before the age of menopause.
Next question for Dr. Serrano. Do the bones of men also weaken like women during this stage in life?
Unfortunately, Karen, the answer is yes. No. So apparently, menopause and osteoporosis and andropause and osteoporosis go hand in hand. If you look at this matrix of normal bone and the other matrix of decreased bone mineral density in men with low testosterone, you will really see a stark difference in the ultrastructure of the osteoporotic men. It is not just really osteoporosis in general, but in men it is also dangerous because there is a higher risk for hip fracture, as much as 71%, in men who are hypogonadic as compared to 32% of those who are just elderly and no osteoporosis. So this increased risk for hip fractures really portends a very bad comorbidity. You very well know that hip fractures among men leads to a lot of debility, a lot of pneumonia in the elderly, and eventually really bad outcomes. So osteoporosis is something that we really need to deal with in men who are andropausic.
For Dr. Aguilar, do women in menopause have weaker bones?
So thank you, Dr. Jasmine. Likewise, over the menopausal transition, bone mineral density has already started to decline, even before the menstruation eventually ceases. So another fun fact, despite having lower bone mineral density than whites, Japanese and Chinese women have lower fracture rates. It may be related to bone strength, which decline less among these cohorts, and it also may be related to their lifestyle. So maybe the Japanese and Chinese women well into their older lives, longer lifespan, and older life expectancy, continue to maintain a very healthy lifestyle. In the Philippines, they have collected some data about fracture risk in the elderly, and this data was published way back in 1991. The result of bone density changes and possible decrease in bone strength due to decreased physical activity will increase your fracture risk. In the Philippine Orthopedic Center, the most common type of osteoporotic fractures among menopausal women are of the femoral type. We can only surmise that the forearm fractures listed here as among the most common are due to falls. Compression fractures and osteoporotic type of fracture of the spine round out the top three types of fractures in that age group. Thus, in screening osteoporosis risk, it is best to do a bone scan, not of the calcaneus or the heel, but of the femur or hip and the spine. So preventing falls in that age group because of some neurologic or balance issues is also a protective measure against fractures.
Next question for Dr. Serrano. Does the decrease in a man's sex drive and his inability to sustain an erection automatically mean he is already in andropause?
I'd like to say no to that, Karen, because we see a lot of young men who have a reduction in libido and a reduction in their erections for other reasons rather than low testosterone levels. But for the elderly male, the definition of androgen deficiency syndrome or andropause has actually been defined by the ISSAM, or the International Society for the Study of Aging Male. And it, just puts forth three cohorts. One is advancing age, two is typical symptoms, and the third is low testosterone or a deficiency in serum testosterone levels. So if you look at the European study for the aging male, it actually proposes the minimum criteria for the diagnosis as three sexual symptoms: decreased libido, decreased morning erections, and erectile dysfunction. So for the elderly male, if you have reduction in erections and libido, I think it will be safe to say that this is correlated to low testosterone levels. But in the younger male, below 40 or 30, even at 30 years of age, if they present with erectile dysfunction and loss of libido, then we have to look for something else, because most likely their total testosterone level is not yet low, mainly because of their younger age. If you want to be academic about it and you really want to measure testosterone levels, the definition of a low testosterone is a total testosterone level of less than 11 nanomoles per liter. And if you want to test this, there's a diurnal variation in testosterone production. So we really recommend that you get a blood extraction, or that your patients get a blood extraction for serum total testosterone somewhere between 7 and 11, 7 in the morning and 11 in the morning. And that's really when testosterone production peaks in many men. But going back to your question, is the reduction in libido and the reduction in erections enough to diagnose andropause? If we look at the ADAM questionnaire, or the androgen deficiency in the aging male questionnaire, that is essentially a self-administered questionnaire trying to pick up andropause. An answer of yes to either the question of do you have a decrease in libido, or the question of number 7, are your erections less strong, automatically puts you in a suspect for low testosterone levels. So given the proper context, you have an elderly male, you suspect low testosterone, and he presents with reduction in libido and less erections, then I think you have to consider that andropause is getting along in this man.
The next question for Dr. Aguilar: can a woman still get pregnant even if she's already at the perimenopausal stage?
Thank you, Dr. Jasmine. The answer is yes. You see, the perimenopause stretches 1 to 3 years before and after that final menstrual period. And because it's quite a stretch, then occasionally ovulation may happen. And if ovulation does happen, then the possibility of getting pregnant is there. So for women who would like to avoid pregnancy and who are luckily still sexually active during that phase, then there are safe choices for contraception. And we should confine our choices to those contraceptives belonging to what we say category 1, according to the medical eligibility criteria by the World Health Organization or the US Medical Eligibility Criteria chart. And that means that we should avoid prescribing estrogen-containing preparations commonly found in combined oral contraceptives. For this age group, we would prefer progestin-only preparations such as an implant, a progestin-only pill, or even a levonorgestrel intrauterine system. However, we should limit the use of dipomedroxyprogesterone acetate, or DMPA, as it is known to compromise bone density, which is a risk in this women's age group.
For Dr. Serrano, is there a higher risk of prostatic enlargement and/or prostatic cancer during andropause?
Actually, Karen, prostate enlargement and prostate cancer is essentially a disease of the elderly male. Contrary to whether it is caused by andropause or not, it is actually driven by testosterone levels. It's just that prostate cancer and BPH happens in the elderly men even when their testosterone levels are low, mainly because of the fact that their prostates have been exposed to testosterone for decades on end. So that is why, at that age, 50s, 60s, they would have sustained, the prostate would have sustained enough testosterone exposure to become hyperplastic, or sometimes to become even malignant. So really, all elderly men are at risk for prostate enlargement or BPH and prostate cancer, mainly because of their age. The other factors that actually put them at risk for prostate cancer is their genetic predisposition. If they have a father, a grandfather, or a male sibling that has prostate cancer, that essentially ups their risk for prostate cancer as well. And of course, environmental factors, fat intake, lifestyle, and all of that. So prostate cancer, prostate enlargement is actually driven by high testosterone levels. But even if the testosterone levels dip in andropausic men, they would have already have enough hyperplasia or prostate enlargement, or even the onset of the development of malignancy by this time. Other than prostate cancer and BPH, I'd like to also highlight the other comorbidities of andropause that actually impacts the longevity or the survival of these men. And in this algorithm, you will see that everything is tied together. Hypogonadism or low testosterone is tied together with heart disease, obesity, hypertension, dyslipidemia, type 2 diabetes mellitus, and insulin resistance, all contributing to what we have discussed earlier as the metabolic syndrome. And I think for a more holistic approach to the andropausic men or to the andropausic man, we really have to consider also treating or also addressing these comorbidities that occur in these elderly males.
The next question for Dr. Aguilar, is cancer of the uterus or ovaries greater for menopausal women?
Thank you, Dr. Jasmine, for that question. Any cancer, for that matter, increases as the age increases. For ovarian cancer, unfortunately, we may not be able to detect that quite early, as screening methods are not very sensitive for ovarian cancer as of this time. But if the patient has a medical history or a strong family history of ovarian cancer, then definitely it may be cost effective for her to do a regular screening, risk screening, as well as to visit the gynecologist to be able to see whether there are non-specific symptoms that may lead to eventual discovery of an early ovarian cancer. With regards endometrial cancer is related to anovulatory cycles. Anovulatory cycles are actually, with regards uterine cancer, what we call endometrial cancer, they're more associated with anovulatory cycles. So anovulatory cycles occur frequently in the perimenopause, and anovulatory cycles may occur in women with endocrinopathies, for example, polycystic ovary syndrome. But endometrial cancer is easy to detect because women are having menstrual irregularities and they may manifest with abnormal uterine bleeding. So for the women in the perimenopause, any prolonged amenorrhea and eventual heavy menstrual bleeding should all be investigated. But what is being neglected is breast cancer. With all the risks accounted for, breast cancer, while a dreaded diagnosis, was actually found to be associated with an increased life expectancy in this population-based study in Norway. So applying these findings to other populations, again, an increased life expectancy should be aided by early diagnosis of cancer, whether it's breast, endometrial, or ovarian, through diligent screening by us, the healthcare provider, because this will greatly improve the survival rate of these women, enough for them to enjoy their remaining years.
And finally, for Dr. Serrano, is there treatment?
Yes, Karen. Hope springs eternal even for the elderly male. But before I answer the question of is there treatment, maybe I should tackle also the question of why should we treat? Because really, I get a lot of questions from my patients. Doc, if it's really part of aging, why should we treat? Or doc, sex is no longer important to me. I just want to play golf. Why should we treat? So I think there are two very good reasons that actually drives the impetus for treatment. One is the fact that low testosterone levels is actually increases the risk of death among our elderly males. If you look at this study that was done by Shores looking at more than 800 men above 40 years of age, for those with normal testosterone, the mortality rates were around 20 or 1 in 5, 20%. But for those with low testosterone, it's as much as 35% mortality risk and mortality rate. And really, that's an 88% increased risk of mortality as compared to those with normal testosterone. Looking prior to death, really, we discussed a lot about the comorbidities, diabetes mellitus, metabolic syndrome, and cardiovascular disease. And we now know that all of these are linearly correlated with testosterone levels. And if we want to prevent further comorbidities for these men, further complications of diabetes, further complications of coronary heart disease and dyslipidemia, then really we should address the total testosterone levels in these men, and we should treat testosterone, the low testosterone state. So that is that is for me, these are the driving factors, or the primary reasons why we should treat men with low testosterone or men who are in andropause. Of course, treatment is optional for these men if they are really bothered by the signs and symptoms, and if they're really bothered by all of these metabolic and musculoskeletal complications, then really this is also what will bring men to the urologist or even to the geriatrician to get their andropause treated. And how do we treat? Well, like I said, there is treatment, and really treatment is total testosterone replacement. And when we look at testosterone replacement, we look at the total testosterone in the serum of our men. If we go by the value of 12 and above as being normal, then if you have men who are greater than 12 nanomoles per liter of total testosterone, then testosterone replacement may not be needed for these men. You may really need to just find out if their other comorbidities will need treatment. For those whose values are less than 8 nanomoles per liter, then really these are men who will benefit most, from testosterone replacement. And everything in between 8 to 12, you will have to go by symptomatology and by the goals of your patients. If they are really bothered by andropausic symptoms, then you may consider testosterone replacement in these men. So 8 to 12, and 12 are the numbers that we go by in terms of determining whether we should replace testosterone. What are our goals? Well, the target level really is to achieve a level in their serum of above 14. Anywhere from 14 to 17.5 really is the target level. Higher levels may be necessary for older men who are refractory to testosterone replacement. But really, if your patient has been on testosterone replacement for 3 months or more and are still symptomatic, then you may need to do a little bit deeper, a deeper dive into all of their symptoms and find out if there's any other organic issue that is driving all of their symptoms. There are testosterone preparations available in the market. The most popular are the injectables, testosterone in undecanoate, as an injectable that is given once every 3 months. And this actually has better prediction of serum total testosterone. There are oral capsules available also of the undecanoate format. But really, I think the most reliable testosterone replacement preparations are the ones that are given intramuscularly, either undecanoate, cypionate, or enantate. And like I said, these are the ones that actually give better predictions in terms of serum total testosterone. There is, however, a couple of controversial issues of risk for testosterone replacement. Like we discussed before, prostate enlargement and prostate cancer really is driven by testosterone. So before giving testosterone for these men, you will have to rule out that the patient has significant prostate enlargement causing lower urinary tract symptoms, because that will lead to a worsening of their symptoms of BPH. Worse, if they have an occult malignancy, then you may actually drive that malignancy into, you may actually awaken that malignancy and drive it into progression. So mandatorily, I would urge everyone to check the PSA levels of these men. Invariably, men above 50s, in our day and age, already all get PSA determination. So you may just need to ask them, have you had a recent PSA done? And any PSA level above 4 really, rings alarm bells for possible prostate cancer. So get a PSA for these men, get an ultrasound, check the size of their prostate. You may have to warn them about enlargement of the prostate over prolonged use of testosterone or exogenous testosterone, and a bit worsening of their symptoms. Male breast cancer is also driven by testosterone. So I think this is very easy to check, but a lot of us neglect it because we don't actually examine the male breast in the clinic. But you may have to ask your patients if they have a history of male breast cancer, if they actually have feel a lump in their chest, and you may actually need to do a physical examination for these men. Other risks other than BPH, there's a little bit liver toxicity because testosterone is metabolized by the liver. Hyperviscosity syndromes because of increased RBC production and erythrocytosis. A little bit of worsening of sleep apnea or congestive heart failure. So really, for men with cardiac issues, you may need cardiac clearance, or you may need to consult your friendly neighborhood cardiologist before you start putting these men on testosterone replacement. I think that's my last slide.
And for the last question for Dr. Aguilar as well, is there treatment?
Okay. Thank you, Jazz. Who will need treatment during the menopausal transition? Maybe not all, 75% who experience symptoms, but certainly relief may be needed by a quarter developing severe symptoms, and a third who may find the long duration of symptoms unbearable. Remember, menopausal transition may not be short for many a woman. Some women will feel that their menopause is like their menstruation quit like cold turkey. But for some, it may drag on for years, even 4 to 7 years. So can you imagine how unbearable that would be? So the mainstay in the treatment of these symptoms is, of course, menopausal hormone therapy. Compared to placebo, only this type of treatment has been found to consistently improve the symptoms and improve the overall quality of life. And when I say menopausal hormonal therapy, it involves the use of both estrogen as well as progesterone preparations, the latter being given for women who still have their uterus. However, not all women find this treatment suitable or acceptable. So a series of randomized controlled trials that I showed you earlier, nicknamed MS Flash, short for menopausal strategies, finding lasting answers of symptoms and health, studied 6 interventions on healthy menopausal women experiencing bothersome hot flashes. Domains such as psychosocial functioning, sleep, and overall quality of life improvements were measured, and estrogen, as well as selective serotonin reuptake inhibitors and cognitive behavioral therapy for insomnia, are most significantly associated with improvement within the month. These are the lines or curves that you see in the bottom half of the graph. Okay? Over the long term, a non-pharmacologic intervention, yoga, seems to prove to have some benefit. So exercise, however, as well as omega supplements, do not demonstrate significant improvements. So expectedly, estradiol is the most effective for vasomotor symptoms, and SSRIs are for psychosocial functioning improvement. So surprisingly, SSRI in the form of escitalopram provides earlier improvement in physical domains. So like I said, the symptoms may also be related to the mood that or depression or anxiety that the woman experiences in the transition. So interestingly, cognitive behavior therapy for insomnia has the greatest impact, as I said, on sexual domains. So maybe getting a good night's sleep will actually improve your sexuality. So if there is a concern for breast cancer, here are the considerations. So whether estrogen alone or combined with progesterone, the duration of menopausal hormonal treatment increases the risk of diagnosis. So, and it is higher with continuous combined compared with just cyclical administration. The risk remains elevated even if you discontinue menopausal hormonal treatment. However, the risk is not dose dependent. And luckily, vaginally administered estrogen does not increase the risk. So if you have sexual dysfunction related to physical discomfort during intercourse, then maybe the better option to give is a topically administered estrogen preparation. So therefore, given these, the alternatives to improve the quality of life of women are varied. You can go for menopausal hormonal treatment using your hormones. You can use SSRIs for psychosocial and cognitive, as well as mood concerns. You can improve your vasomotor symptoms with just MHT, but there may be other ways of improving it using other types of interventions, even yoga. So for every uh, concern, there is an appropriate way of approaching menopausal hormonal treatment. And that should be well inculcated in the woman when you open the conversation about treatment. Some women are already at home, or shall we say, used to their menopausal symptoms, and they're just happy that they are affirmed with regards to the existence of the symptoms. All you have to tell them is just to reassure them that this is part and parcel of the transition, and they may not need to actually take any medication. But for those who are really severely impacted by the symptoms, then the discussion should uh, be able to cover the topics of doing hormonal therapy or other interventions that may actually relieve the women of these symptoms and improve their quality of life and function.
Thank you to our speakers, Dr. Serrano and Aguilar. Now it's time to answer questions from our audience. Let me call in our moderators for this session along with our two speakers.
Hi. Hi, Dr. Serrano. There's a question for you right away from one of our attendees. The question is actually from one of your colleagues, Dr. Jeff Vilado. Does exogenous testosterone, like the ones that's being taken by weightlifters, I guess, increase the risk for prostatic cancer?
So I think the question is exogenous testosterone or exogenous steroids. If he is taking steroids, it depends. If the steroids is sort of like an analog of testosterone, like mesterolone, then it acts, it acts in the same way like a antigen receptor complex, ligand receptor complex. It will activate the same pathway for activation for hastening of prostate cancer if you have the genetic profile for prostate cancer. So technically, we do not recommend exogenous steroids if you do not actually need it. If you use it for muscle building, then it has to be under supervision by a physician. If you're using prednisone or dexamethasone, those have not yet been correlated with the development of prostate cancer. But if you are using a testosterone preparation or a testosterone analog like mesterolone, then you are, that actually can hasten. I hope that answers the question. Yeah.
Thank you, Dr. Serrano, for answering the first question. Now, I'll be posing a question for Dr. Aguilar. It's a question raised actually via YouTube by Dr. Ramirez. Are bioidentical hormones of greater benefit than synthetic hormones for menopausal women?
Thank you, Jasmine. That's a very interesting question. And we at our Philippine Society for Reproductive Medicine would like to look into this because bioidentical hormones has been in the market already. Many practitioners are using it, and many patients are actually ordering it online. So that's a big concern of ours. And these bioidentical hormones may not actually, we don't really know whether they're product registered by under the FDA, and we don't have any practice guideline covering these hormones. So to be fair, what we're prescribing now is what are FDA registered, and what is available locally in the Philippines are as follows: Tibolone 2.5 milligram tablet, that will cover both your estrogen and progesterone. You can give that for women with intact uterus. And estradiol preparations, you can give by tablet, you can give by topical form or a vaginal form. And then you can also use progesterone orally. There are many progesterone preparations so that you can protect the endometrium. You can give medroxyprogesterone acetate, norethistron, as well as dydrogesterone. And all of these are just designed to protect the endometrium when you're already giving an estrogen preparation. So while these are synthetic, these are registered, and the adverse reaction or the events that are related to administering these drugs are already guaranteed based on studies, based on the licensing or the registration of the product, and based on worldwide practice guidelines, not just our own. With regards bioidentical hormones, we have yet to provide a guideline as to how these are responsibly used, what effects we should be expecting of them, and what dose or preparation will be suitable for the indications that we have seen in our patients. So that's something that we really have to consider. And we are aware that functional medicine specialists are already using that and giving that to our patients. So we would like to meet on it and find out whether we should make a stand as a society, whether it's the Philippine Obstetrical and Gynecological Society or the PSRM, or also our advocacy group, the PSCM, to find out whether these bioidentical hormones will fit into our standard practice guidelines in terms of our standard therapeutics for menopausal symptoms.
Okay, thank you, Dr. Aguilar. Another question for Dr. Dennis Serrano from an anonymous attendee. Does taking finasteride for androgenetic alopecia affect or contribute to the development of andropause?
Okay, thanks, Karen. Finasteride is actually a 5-alpha reductase inhibitor. It does not lower your testosterone or it does not raise your testosterone, but it prevents conversion of testosterone to dihydrotestosterone. And dihydrotestosterone is the one that is used by the end organs. So the side effect really is for hair growth. Maybe I should take low dose finasteride. But also the side effect for the higher dose finasteride is to prevent prostate enlargement or to reduce an enlarged prostate. So there are a lot of men taking it. So, and that's for those two effects, no, reduction of prostate growth or for alopecia or for hair growth. And the side effect, unfortunately, is similar to andropause. It's loss of libido and erectile dysfunction. So it induces a pseudo-andropause. It induces a pseudo-andropause state. When you have low dihydrotestosterone, then you get loss of libido, you get erectile dysfunction, you get all of the caveats that we've mentioned that go with andropause. So it is an artificial andropause. Unfortunately, for many men who are elderly and who take it, even after taking it, you don't recover, or sometimes it's difficult to recover testosterone again. So it may herald, or it may actually be one of the causes for early andropause if you start taking the medication. But be that as it may, we only prescribe finasteride really for men who have indications for it, and usually these are already elderly men, and they already have these signs and symptoms. So the side effects. So yes, to a certain extent, it will create a pseudo andropause state in you.
Thank you, Dr. Serrano, for answering the question. And then we have another question as well for Dr. Aguilar in relation to the talk on testosterone, but with regards to women. Do you recommend testosterone replacement, low dose, for menopausal women as well?
Well, testosterone therapy has a place in menopausal treatment, and it's supposed to be beneficial for women who may think that libido is a problem. So very interesting, no? So if Dr. Dennis is using testosterone for libido, we can use the same thing. So one prescription, no? We can share that, Dennis. And but some preparations may actually have androgenic effects. For example, some progesterones have an interaction with the androgenic receptors. For example, if you're using medroxyprogesterone acetate or norethistone acetate to protect your endometrium, then you will have interaction with the androgen receptors, and maybe you can hit two birds with one stone. So with just testosterone alone, we have to watch out for the other unwanted effects of testosterone for a woman. For example, they may aggravate hair loss, so androgenic alopecia may set in. When you're already having thinning hair during the menopause or the perimenopause, you don't want to aggravate that. Also, because androgens rise at about the time because of unopposed estrogen, then the problem is that some women may actually have skin breakout. And, it's horrible if a woman goes through this menopause, losing her period, losing her hair, and then her skin breaks out. Then we will have to see Dr. Karen Alabado in her clinic because we have to restore our youth and beauty. But then again, like I said, what we are trying to counsel women in this transition is that there are many aspects of menopause that they have to attend to, not just the physical, but the psychosocial as well. And we really have to support women going through this because it is not just a physical thing. It has to affirm her well-being by looking into her worth and to be able to realize her to have self-actualization as a woman at that age.
Okay, so thank you, Dr. Angge Aguilar, and of course, Dr. Dennis Serrano. We're running out of time, but we have a lot of questions in our Q&A box. So I'd like to invite you to answer by typing so that the questions can be answered. And I'd like to call back our chair and co-chair to wrap up the session.
Thank you to our dear speakers and moderators for that very enlightening discussion. We would like to award the Certificate of Appreciation to Dr. Dennis Serrano in grateful recognition for his invaluable contribution as speaker in our session entitled He Said, She Said, Current Concepts in Andropause and Menopause during the UP College of Medicine Grand Scientific Symposium. The Certificate of Appreciation is given to Dr. Angela Season Aguilar in grateful recognition for her invaluable contribution as a speaker in our session entitled He Said, She Said, Current Concepts in Andropause and Menopause during the UP College of Medicine Grand Scientific Symposium. We would also like to award the Certificate of Recognition to Dr. Karen Lee Alabado and Dr. Jasmine Therese Arcilia for their contribution as moderators for the focus session on aging, given this 23rd day of September 2021. Signed by Dr. Maria Assumpta Cecilia R. Serrano, President of the UP Medical Alumni Society Davao Region and overall Chairman of the Organizing Committee, Dr. Teresa Luisa G. Cruz, Director of the Postgraduate Institute of Medicine, Dr. Charlotte M. Chong, Professor and Dean of the UP College of Medicine, and Dr. Lara Teresa Alentahan Aleta, President of the UP Medical Alumni Society. Thank you, doctors.
Dan Arcilia for moderating the session, and of course to our excellent speakers, Dr. Angela Aguilar and Dr. Dennis Serrano. So in summary, in the He Said portion, we learned that andropause deficiency syndrome, otherwise known as andropause, varies as to age of onset, with physical and emotional well-being affected. Virility, metabolic syndrome, and osteoporosis are major problems, but there are various treatment options that can be given.
And for the She Said part, what we learned from Dr. Aguilar's lecture are these tenets. So menopause usually occurs during the 47 to 48 years of age. However, some will experience menopause at the early 50s. So menopause is inevitable. So don't forget the 7 dwarfs of menopause. itchy, bitchy, forgetful, sleepy, sweaty, bloaty, and cycle. A certain number will have different symptoms. However, some may have bearable symptoms. Hence, most will not go for any consultation. However, for women with unbearable symptoms, treatment for menopause will still be menopausal hormonal therapy. This is still the mainstay of treatment for menopause, with good relief of symptoms and good quality of life as observed by most patients.
With this, we'd like to thank you all for joining us, and please stay on for the next two sessions. Good afternoon.
Good afternoon.
Our next lecture is entitled Blood Booster, Optimizing Blood Health for Women of Reproductive Age, to be given by Dr. Brenda Bernadette Zamora. This is an industry-sponsored lecture from Abbott.
Our lecture will be on Blood Booster, Optimizing Blood Health for Women of Reproductive Age. For my disclosure, I'm a speaker for Abbott Women's Health. For the objectives of this lecture, first, we aim to increase the awareness of the impact of blood health on women and likewise on their future generations. Moreover, we will discuss blood health interventions according to global guidelines with emphasis on micronutrients during the reproductive age. And lastly, we aim to review the recommendations on both iron and folic acid supplementation in the context of iron deficiency anemia in pregnancy. For the outline, first, we'll start off with a blood health check. We'll discuss women's health, blood health, and preconception nutrition. Then we shall proceed with blood boosters, and that would be the interventions and global guidelines, present to you the World Health Organization and likewise the FIGO recommendations. Also, for blood booster, we shall discuss iron supplementation and your iron supplement of choice. And lastly, we'll get some updates on blood health today. First, let's start off with a blood health check. We all know that anemia in pregnancy is indeed a global health problem. 30% of reproductive aged women are anemic. If we take a look at the statistics of the World Health Organization, the estimates of the prevalence of anemia in pregnant women is at 40%. Now, socioeconomic status and nutritional deficiencies, they both contribute to the variations in regional and likewise global prevalence reports. Let's take a look at local anemia prevalence. This graph on your left, we see the prevalence of anemia among pregnant women. Reported from year 2005 to year 2016, we see a marked decrease from 42% to just 30%. But just the same, according to the World Health Organization and the UNICEF, anemia is an indicator of public health, for which a level of 30% would still be categorized under moderate public health significance. Now, iron deficiency is most common at times in life where iron needs increase. Example, during early childhood, during menstruation for reproductive age women, and of course during pregnancy. Majority of anemia in reproductive age women is due to low or absent iron stores, making iron deficiency anemia the world's most common anemia due to a micronutrient deficiency. What are the factors that can contribute to iron deficiency? We have several. Let's name a few. You have insufficient dietary iron. Also, you can have blood losses from previous pregnancies, let us say, or from the monthly menstruation. And also, of course, secondary to underlying conditions that can preclude your adequate iron intake or impair the iron absorption. To give you examples, example for cases of those who present with nausea and vomiting during pregnancy, those who have inflammatory bowel disease, those who have had bariatric surgery, and of course, other conditions. The iron requirements increase dramatically throughout pregnancy, and this is due to the expanding blood volume of the mother and the iron requirements for fetal RBC production and also for fetal placental growth. Let's take a look at this graph on your left. This shows you the approximate iron requirements needed to compensate for To start off, let's check for normal turnover. That would be at about 1 milligram of iron per day. And also for menstruation at about 1 to 2 milligrams per day. Come second trimester, you have expansion of maternal RBC mass, and that would cover about 4 milligrams of iron per day. And come later in pregnancy, by third trimester, you have fetal-placental growth, and that will need about 6 to 7 milligrams of iron per day. Now let's go to the definition of gestational anemia. According to the World Health Organization, that would be a hematocrit of less than 33% and or hemoglobin of less than 11 grams per deciliter at any time during pregnancy. Now, if you look at the definitions according to the CDC, and similar to that of the definitions in our clinical practice guidelines, that would be hematocrit of less than 32% and or hemoglobin of less than 10.5 grams per deciliter come second trimester, or a hematocrit of less than 33% and or hemoglobin less than 11 grams per deciliter during the first and third trimesters. Let's take a look at the adverse perinatal outcomes of anemia in pregnancy. Let's start off with maternal outcomes. We see here a reported maternal death odds ratio of up to as high as 2.36. Now, other advanced pregnancy outcomes will cover blood transfusion, antenatal and postnatal infection, cesarean deliveries, and even later cardiovascular disease. Now, as to neonatal outcomes, you have preterm birth, low birth weight, and small for gestational age neonates. Interestingly, if we review literature, there are now new reports that anemia in pregnancy can also increase the risk of your autism spectrum disorder, attention deficit hyperactivity disorder, and your intellectual disability, with a reported odds ratio of 1.4 to 2.2. Now, the International Federation of Gynecology and Obstetrics, like the FIGO, now calls for increased awareness of the impact of women's nutrition on themselves and likewise on their future generations. So they now call for action so we can improve the nutrition among our adolescent girls and likewise women of reproductive age. We see here the central role of nutrition in determining health across life course and across generations. In all stages in a woman's life, we see that it is connected by the effects of both good and poor nutrition. Poor nutrition at any stage has negative consequences that can disrupt the cycle and also impact later life stages. Let us take a look at this diagram. If there is poor nutrition during the adolescent period, you can have those who will grow into poor school performance, they have impaired reproductive health, and are prone to chronic illness. If we take a look at women of reproductive age, with poor nutrition, they have reduced work capacity and poor family care. Now, poor nutrition during pregnancy and breastfeeding, we all know that that would render us at increased risk for both maternal and neonatal morbidity and mortality. Interestingly, even if we look at the outcomes, infant, young children with poor nutrition, they're more prone to stunting, poor cognitive development, and they would be at increased risk for both acute and chronic diseases. Let's take a look at the World Health Assembly Global Nutrition Targets for year 2025. And one of the targets would include your anemia. The target is 50% reduction of anemia in women of reproductive age. Now, interestingly, we also have our own local health goals. Well, primarily, the basis would be previous studies that also showed that in our country, we have inadequate delivery of your micronutrient supplementation, especially among adolescents. And that is why we have the Philippine Plan of Action for Nutrition for years 2017 to year 2022. This has been aptly called your Ambition 2040 or the Philippine Development Plan and Sustainable Developmental Goals. It has nutrition-specific and nutrition-sensitive programs which in the long run would aim to reduce micronutrient deficiencies. To meet the local health goals, we have several interventions, and they come in the form of policies, plans and strategies, and also programs. Examples of your policies, you have your Expanded Breastfeeding Promotion Act, your Food Fortification Law, and the first 1,000 Days Law. Interestingly, there was this updated publication in year 2020 by the group of Dr. Padilla et al. This was on identifying challenges to the quality of preconception healthcare among women of reproductive age in Lipa City, Batangas. This study was a thematic analysis of data wherein they carried out focused group discussions. They were able to enroll more than 4,300 participants, for which they carried out preconception checklist tools. And what did the results show? They mentioned that there were indeed salient gaps in preconception healthcare, particularly when we discuss micronutrient intake. Moreover, the results showed that there were major gaps both in medical and educational services, particularly among the adolescents. Let's take a look at their results. The first table above shows you the frequency of micronutrient intake according to the age of the study participants. Let's start off with that of the adolescents and focus on folic acid and iron tablets intake. For folic acid, that's only 5%, and iron intake at only 12%. Even if we take a look at women of reproductive age, for folic acid, that would be maximum of about 25%, and for iron intake, only 40% of these women in reproductive age. Now, even if we focus on the second table below, on micronutrient intake according to study sites, let's go check your rural communities. Again, even for folic acid, the rate is only about 20% and only 37% for iron supplement intakes. So indeed, micronutrient malnutrition is a local concern. That is, vitamin and mineral deficiencies that are secondary to several factors. Maybe one would be due to inadequate intake. Two, maybe because of the low bioavailability of the nutrients in the food they take in. Or lastly, maybe because of increased nutrient requirements. Example, during pregnancy. So during pregnancy, when there's micronutrient deficiency in the mother, this translates to deficiencies in the fetus and likewise to that of the newborn. Now, what are the nutrients of concern? We have your iron, folate, and vitamin B12. Also included would be your calcium, vitamins A and D, and zinc, and your iodine and selenium. Now let's go to blood booster interventions and global guidelines. So we have interventions to control micronutrient deficiencies among the adolescent girls and likewise among women of reproductive age. And they can be broadly divided into three. You have your dietary modification, supplementation, and fortification. So let's start off with dietary modification. This means that we aim to improve the variety in the diet. We improve the intake, the absorption, and the utilization of both vitamins and minerals. Let's take iron, for example. So we encourage intake of food that is rich in bioavailable iron, like your meat and vegetables. Also, we encourage them to review the food processing techniques. Example, we aim to use fermentation so we can reduce the phytate content. The phytate is an iron inhibitor. How about vegans? Well, they may choose to eat animal products, or now they can tailor their diets with the use of nutritional yeast that has now been fortified with vitamin B12. We also have supplementation. This is the direct provision of vitamins and minerals in the form of liquid, pill, tablet, or dispersible formulations. So what are the current supplementation efforts focused on? Well, primarily on iron, folic acid, your iodine, calcium, and of course, you also have your multiple micronutrient formulations. We also have your food fortification. That means the addition of one or more essential nutrients to a food for the purpose of preventing or correcting a demonstrated deficiency of one or more nutrients in the general population or given specific population groups. So for food fortification, we address the food processing, care of that of the food industry. Example, for staple foods, it's already mandated to fortify at least one industry milled cereal grain, mainly with both iron and folic acid. Now, fortification with iron and folic acid has proved to be an effective and safe strategy to reduce anemia and also decrease the incidence of your neural tube defects. Other food fortification processes can focus also on condiments and seasonings. So your soy and fish sauces, curry powder, your bouillon powders or bouillon cubes may also be useful alternatives for iron fortification. Now, we also have nutrition-specific interventions for the adolescent girls and women of reproductive age. So here, let us take a look at the suggested scheme for your iron supplementation. Here we have your once weekly, that means 60 milligrams of elemental iron with 2,800 micrograms of folic acid given in 3-month cycles, meaning 3 months on and 3 months off. Then the other scheme would be giving your iron daily at a dose of 30 to 60 milligrams of elemental iron for 3 consecutive months per year. Now here, evidence shows that with intermittent iron, the first scheme, it can reduce the likelihood of developing anemia by as much as 30%. Now, based on evidence, if you follow the second scheme, that can reduce the likelihood of having anemia by as much as 70%. Now, let's take a look at folic acid supplementation. The suggested scheme would be a daily dose of 400 micrograms of your folic acid at least 2 months before conception up to the first 12 weeks of pregnancy. And based on evidence, the intake of your folic acid at this period can lower the incidence of your neural tube defects by as much as 70%. Now, let's take a look at the FIGO recommendations as to the daily intake requirement let's focus on folate and vitamin B12 first. For folate, that would be 400 micrograms, and for vitamin B12, that's 2.4 micrograms during the pre-pregnancy period. And come pregnancy and lactation, for folate, that would be 400 to 600 micrograms per day, and for vitamin B12, that would be 2.6 to 2.8 micrograms per day. How about your iron? This was the initial recommendations of FIGO, but however, for population where there is increased incidence of anemia, the recommendation now is 60 milligrams of elemental iron in the pre-pregnancy period, and likewise, 60 milligrams of elemental iron again during the pregnancy and lactation. Interestingly, there were several publications that questioned the need for doing your iron supplementation during pregnancy. But first and foremost, maybe it's nice to know that nutritional iron deficiency is the most widespread nutritional deficiency disorder that affects more than 2 billion people worldwide. And it is iron deficiency that is the major cause of anemia in pregnancy. And so they ask, should iron supplementation be a routine during pregnancy? Well, if you check on the recommendations of the World Health Organization, they suggest weekly supplement of your iron folic acid so that we can avoid iron deficiency anemia, and its negative outcomes for the pregnant women and the child as the gestation advances. Moreover, they want to implement fortification programs for foods, more so for iron and folic acid. So if you ask again, should iron supplementation be a routine during pregnancy? Well, the answer would lead to assessment for pregnant women in developing countries, or if in situations where screening for iron deficiency anemia is not adequate, or if it is not possible, then it is suggested that your iron supplementation be given during pregnancy. Also, there are several publications with regards to questions on concerns on other effects or benefits from the use of giving your folic acid during pregnancy. Is it more than just neural tube defect prevention? Well, here, interestingly, your folic acid has a very big role in the prevention of anemia. We see here that in active erythropoiesis, we need adequate supply of 3 key nutrients, and that would be your folate, your vitamin B12, and your iron. We see here that based on results of retrospective studies, women on high folate and high vitamin B12 group demonstrated significantly higher hemoglobin levels as compared to those women who were on regular vitamin intake. So, Indeed, folic acid is more than just neural tube defect prevention. If we review literature, we can see that with intake of folic acid during pregnancy, it is associated with the prevention of anemia, also your preterm birth, congenital heart disease, and oral clefts. New literature even shows now that studies have been focused on the association of your folic acid supplementation and the decrease in placenta-related complications in pregnancy, like preeclampsia, abruptio, fetal growth restriction, and even fetal death. Now let's go to blood booster and talk about iron supplementation and the iron supplement of choice. Let's take a review of the recommendations according to our local CPG. Here we see that daily iron and folic acid supplementation is recommended as part of our prenatal care. This is so that we can lower the risk of maternal anemia, puerperal sepsis, outcomes of low birth weight, and preterm births. Now, for women who cannot tolerate daily iron intake, maybe due to GI upset or some side effects, or if the prevalence of anemia in that particular population is less than 20%, the recommendation can be intermittent oral iron supplementation at 120 milligrams of elemental iron with 2.8 milligrams of folic acid given once weekly. Now, in settings where anemia in pregnant women is a severe public health concern, the recommendation is 60 milligrams of elemental iron with 400 micrograms of folic acid compared to the initial recommendation only at 30 milligrams. Now, if a woman is diagnosed with anemia during pregnancy, she should be treated with 120 milligrams of your elemental iron until her hemoglobin concentration rises to normal. And when that happens, she can subsequently switch to the standard dose to prevent the recurrence of anemia. Now, iron supplementation should be doubled at a dose of 120 milligrams of elemental iron if the woman is large in size, is pregnant with multiples, is beginning supplementation late in pregnancy, or if the woman has been taking her iron supplements irregularly. Here we have a systematic review publication just recently with regards to an evaluation of the tolerability of different oral iron supplements. We all know that when you give your iron supplements, this can be associated with erosive mucosal injury of the upper GI tract. So we have patients who would complain of nausea, vomiting, they experience epigastric discomfort. The others would complain of diarrhea, while the others would complain of constipation. So indeed, there is a direct relationship between the number and the severity of these adverse effects and that of the dose of iron that is administered. And with that, this can affect compliance. And to some patients, it will even cause them withdrawal from treatment. So it is interesting to note that there are now new formulations that have been developed with regards to iron supplementation. Examples, they have formulated delayed release so that it can improve the GI tolerability and bioavailability. The others, they included vitamin C in the formulation so it can promote iron absorption. Others, they can add their mucoprotease and it can cause prolonged release of the iron and subsequently protect the GI mucosa. So this is an interesting table that shows us the results of the frequencies of adverse effects comparing the various oral iron supplements. We see here that the extended release ferrous sulfate and mucoprotease combination had the lowest incidence of adverse effects, and that was why it was used as the reference supplement. In the study findings, we see here that your extended release ferrous sulfate, that with your mucoprotease, is well tolerated among patients with complaints of GI concerns. Now, the lower incidence of the adverse effects is seen in this compound, most likely would be attributable to its galenical formulation. And what do you mean by that? That means it's the formulation that can lead to an extended release of the iron. It prevents large release of the quantities of elemental iron into the stomach. In so doing, the effect is also reinforced by the addition of your mucoprotease, which is a substance that is rich in amino sugars, which can protect the GI mucosa. So with this new formulation, It improves the tolerability of your iron supplementation. Moreover, it can increase the adherence by as much as 40 to 60%. Now let's do a quick blood health check today. Here we have the results of the recommendations of the European Union, and that would be early nutrition project recommendations for our adolescents and likewise reproductive aged women. So at preconception, one must pay close attention to body weight and BMI and be able to provide advice with regards to modifying diet, lifestyle, and physical activity so we can improve body weight. Also, during preconception, we focus on the intake and likewise the status of some micronutrients, specifically that of folate and iron, more so for the population at increased risk for insufficiency. Now, for pregnant women, we pay attention to one, balanced diet with increased dietary energy intake. Second, we focus on micronutrient intake, specifically that of your folate and iron. And lastly, it is recommended to increase the intake from conception or even before for both your folic acid and your iron. Here, from the Food Agriculture Organization of the United Nations, the UNICEF, the World Food Program, and the World Health Organization, they issued a joint statement on nutrition in the context of the COVID-19 pandemic, specifically for Asia and the Pacific just last year. So in their recommendations, they mentioned maternal nutrition health services should continue to provide essential nutrition services for our pregnant women and also our breastfeeding mothers. Micronutrient supplementation programs should be used to prevent and control micronutrient deficiencies. They should be given routinely as we give services to our pregnant women and when we do follow-up for our young children. Now, for pregnant and your breastfeeding women, we ensure nutrition services that would be providing your iron and folic acid or even your multiple micronutrient supplements. We also provide nutrition counseling and breastfeeding advice during our prenatal care, as long as we do your appropriate infection control measures. They also recommended support for the treatment and care of patients with clinical signs and symptoms of micronutrient deficiencies. This should continue whenever possible, as these are critical interventions, specifically for the supplementation of your iron for your anemic mothers. So in summary, the socioeconomic status and nutritional deficiencies, they both contribute to the variations in regional and global anemia prevalence reports. Now, it's important that we encourage good nutrition to help ensure optimal health for adolescent girls and young women, and so that we can also equip them for future motherhood. Now, micronutrient deficiency should be recognized and rectified through interventions. You have three. That would be your dietary modification, supplementation, and fortification. Moreover, daily iron and folic acid supplementation is recommended as part of our prenatal care so as to lower the risk of maternal anemia, puerperal sepsis, low birth weight, and preterm birth. Now, for women who cannot tolerate the daily iron intake due to the side effects, intermittent oral iron supplementation at 120 milligrams of elemental iron with 2.8 milligrams of folic acid given once weekly is recommended. In settings where anemia in pregnant women is a severe public health concern, the recommendation is 60 milligrams of elemental iron with 400 micrograms of folic acid per day. Now, for women diagnosed with anemia during pregnancy, she should be treated with elemental iron levels at 120 milligrams per day until her hemoglobin concentration rises back to normal. And more importantly, for blood booster iron supplement of choice, we consider the elemental iron and folic acid content and likewise that of its galenical formulation. We consider that with extended or sustained release ferrous sulfate and maybe that one also with addition of your vitamin C. So with that, I'd like to wish you all a good day. Thank you.
Thank you to our sponsors for supporting us in this endeavor. Let us now proceed to our next focus session on mental health. This will be chaired by Dr. Veronica Magnaye and co-chaired by Dr. Catherine Roa.
Good day, everyone. For starters, let's remind ourselves with this. Place your hand over your heart. Feel that? That's called purpose. You're alive for a reason. Don't forget it. We often forget this when we get overwhelmed with challenges, problems, or the novel or difficult situations like the new normal and the ever-changing facets of the pandemic. Bumps on the journey of life can magnify themselves to look like the end of the road where no options seem viable. This helplessness can lead to hopelessness that can engulf one's being. At this point, thoughts of ending it all emerge, and the big S, suicide, comes. Thoughts escalate to plans, and plans escalate to attempts. Nowadays, has come closer and closer to home. It's no longer just a news item. We hear about suicide with friends, friends of friends, classmates, and even relatives. It is but apt then that we have Dr. Cornelio Banag to enlighten us on this topic of suicide and depression. Dr. Banag has always held the flag up for mental health of the children and adolescents, not just on our shores, but beyond the Philippines. He will give us a picture of the landscape in the Philippines of how suicide looks like and give us handles on how to more appropriately address suicide and its related condition, depression. He will talk about warning signs, myths, how to screen and approach the problem, both from the patient and the family side. It's a privilege to moderate this session with one of my favorite persons, and a favorite person too of a lot of people. A mentor, one who inspires us to thrive amid adversity, and a father figure through the years. Let us welcome Dr. Banag.
Dr. Cornelio Banaag Jr. obtained his Doctor of Medicine degree from the UP College of Medicine in 1963. He did his residency training in general psychiatry at the Philippine General Hospital from 1963 to 1966 and his fellowship in child and adolescent psychiatry at the Worcester Youth Guidance Center from 1966 to 1968. He is a professor emeritus at the UP College of Medicine, president of the Philippine Mental Health Association, and a medical consultant at the Medical City.
Thank you, Jessa, for that very kind introduction. And I want to thank the Postgraduate Institute of Medicine for inviting me to be part of this Grand Scientific Symposium. I remember our first Grand Scientific Symposium where I also had the opportunity to give a lecture. So, and thank you also for giving me a very nice title, Bluer Than Blue. When we lose someone because he died, we feel blue, we feel sad. But when we lose a person we love, somebody important to us, by suicide, that's the darkest blue. That's bluer, ever bluer than blue. So, at the end of my lecture, hopefully we shall have learned something about the epidemiology of depression and suicide, some risk factors and red flags, warning signs, a couple of screening tools that we can use, and a general approach to managing depressed and suicidal young people. Although I focus on adolescent, this is very applicable for adults. I only focus on adolescents because in truth, the crisis of mental health right now is in the younger age group, and suicide, a lot of suicide is happening among our teenagers. First, let's recall the meaning of mental health based on WHO. It's a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. Then in 2013, WHO released a fact sheet bringing our attention to the alarming global increase in mental health problems, focusing particularly on young people. The WHO estimated then that anywhere from 10 to 20% of children and adolescents in this world suffer from various forms of mental disorders. And 50% of disorders in adults had actually begun at age 14, but was missed, not diagnosed, until it became so complicated and difficult to treat as adults. And the risk of suicide is highest in the ages 15 to 24. In 2015, the WHO led a survey, Global School-Based Student Health Survey, which is done every 4 years. Presumably, another one was done in 2019, but I haven't seen any of the results. I'm not sure if they did it, but this is the last that we have of the survey among high school students in the Philippines. 13 to 15-year-olds mostly. And when they were asked about suicide attempts, 17% admitted that they have attempted suicide at least once in the past 12 months. 12% admitted seriously considering attempting suicide, and 11% have made plans on how they would commit suicide. These are alarming numbers. And there is a note on the social media envy as a significant predictor of symptoms of depression. And then also a note on a sad state of affair where there is growing demand for mental health services, but we have very limited mental health facilities. Then the pandemic came. This is part of the Philippine One Health University Network and Southeast Asian One Health University Network. The part of the Philippines, this is what came out. When the surveyed NCR students were asked about stress, depression, anxiety, and the impact of event given the appropriate tools, 19% of NCR students admitted to stress of at least moderate to severe in degree. 22% admitted to depression, 36% admitted to anxiety, and close to 26% admitted the great impact of the event on them. When compared to all the other students, the numbers did not change much. But take a look, when they compared it to non-students, you can see a big difference. These youngsters who are not students are much less depressed, less depression, less anxiety, less impact of the event being the pandemic. This is just to underscore the fact that our students are extremely stressed. In fact, there is another part to this survey which compared the students to the general population, and the students continue to be the highest in terms of stress, depression, anxiety, and impact of event. So that the focus had been much on young people. Now, I like sharing this slide because this shows us how did a normal feeling like sad It's normal to feel sad now. It's normal to feel nervous. It's normal to feel angry with what's going on around us in this time of the pandemic. But when did that sadness become a clinical illness called depression? When did the nervousness become a clinical disorder called anxiety disorder? And when did that anger became translated into a manic rage? When did the individual cross that imaginary line? Which brings me to a discussion of noticing the warning signs. We have to be very sensitive and notice the warning signs because depression does not just appear one day. There is a beginning and it takes some time before the full-blown depression becomes recognizable. And some of the warning signs include feeling very sad or withdrawn for more than 2 weeks, seriously trying to harm oneself, sudden overwhelming fear for no apparent reason, intense worries or fears, and changes in the behavior of the young person like involvement in many fights, severe out of control behavior that can hurt oneself or others, not eating, throwing up, extreme difficulty in concentrating, repeated increasing use of cigarettes, alcohol, or drugs, severe mood swings, drastic changes in the student's behavior or personality. School difficulties may in fact be a sign of emerging or unrecognized mental illness. In the days before the pandemic, poor attendance, frequent absences for vague, non-specific physical health problems may in fact be related to underlying mental health needs. Now, they attend the Zoom, but they turn off their video, they turn off their audio. So they are marked absent by their teachers. Difficulties with academic work, adjusting to the social demand of the school, adjusting to school behavior regulation, and the cries for help in social media. These are warning signs that we must recognize. Now, risk factors for depression. This can be environmental or arising from the individual. In the environmental factor, at the top of the list is again school. For some reason, school has become a major stressor for young people. And then, of course, there are relationship problems in the family, with friends, or some budding romantic relationships. Then, of course, social media as a moderator of envy, Facebook, Twitter, Instagram. Individual risk factors can include cognitive distortions, distortions in the way the depressed individual looks at himself and looks at the world, like making personal global attributions like I'm useless, I'm no good, I'm better off dead, a lot of pessimism and negative thoughts. Family and the stability of the environment may be compromised because of serious family fights and conflicts, abusive, unpredictable behavior of parents towards their children, isolation, alienation from family members, multiple losses. I just had a suicidal young man a few weeks ago because two of his best friends are leaving for abroad to study college, and the favorite grandfather just died almost coincidentally. Multiple losses. And he has been depressed and now suicidal. Exposure or experience like exposure to suicidal behavior or actual suicide of a family member, one or more prior attempts on the part of the individual. Of course, comorbid other mental health disorders are risk factors for depression, like anxiety, attention deficit hyperactivity disorder, conduct disorder. There are a number of myths about suicide that we have to recognize. We must not believe this. These are myths. People who talk about suicide do not mean to do it, and they're just waiting for attention. That's, of course, not true. When you say to a young person who has suicidal thoughts and the mother says, anak, tama na yung pag-iinarte mo, that's pushing him to suicide, to act on the suicidal thoughts. Talking about suicide can be interpreted as encouragement. Maybe this is the reason why people generally avoid talking about suicide, even in someone who is apparently suicidal. Even some of us doctors are reluctant to talk about suicide because of the fear that this might push the individual to actually commit suicide. That, of course, is a myth. Only people with mental disorders are suicidal. That's not true. Most suicides happen suddenly without warning. That is the exception. Someone who is suicidal is determined to die. No. The suicidal act is a very ambivalent action. Once someone is suicidal, he or she will always remain suicidal. That's not true. Suicide only happens to certain kinds of people. That's not true. Warning signs for suicide. These are the earliest identifiable signals that a young person may imminently harm himself, possibly within minutes or days or months. And these warning signs may overlap with the risk factors. There are some behavioral clues, like a young person drawing pictures, writing stories or plays that are dark, full of death or suicide, giving away their favorite things like nagpapamana, changes in their behavior, such as going from being quiet to becoming aggressive. There are certain situational clues like the one I mentioned earlier, death of a loved one, especially if by suicide or accident, loss of an important interpersonal relationship. There are certain direct verbal clues like, I've decided to kill myself. Don't take that as a joke all the time. I wish I were dead. I'm going to end it all. Some are indirect verbal or written clues like, what's the point of going on? Soon you won't have to worry about me any longer. A friend of mine, a young person, received a text that worried him. This may be the last time you'll hear me text you. That's alarming. So he called immediately the parent of his friend. Talking, writing about death often, asking questions about death, reading. Well, if you're familiar with Sylvia Plath, I had a patient whose favorite poetess was Sylvia Plath. She was a great poetess who wrote sad poems and eventually killed herself. Screening for suicide and depression may be the important first step to get help with mental health professionals. It helps us provide for a contact for resource persons for an accurate diagnosis and effective treatment. The American Academy of Pediatrics Bright Futures recommends annual screening of children and adolescents for emotional and behavioral problems. I've often asked my pediatrician colleagues, they're expert in screening. Can we include mental health issues in the screening? The U.S. Preventive Services Task Force recommends screening all adolescents ages 12 to 18 years. And in fact, this screening for suicide and depression can be used in primary healthcare setting using two familiar screening tools, the PHQ-9 and the Columbia Suicide Severity Rating Scale, CSSRS. PHQ-9 is self-administered. The CSSRS is clinician-administered. The PHQ-9 is actually recommended by the American Academy of Pediatrics as a valid screening tool for depression in young persons. It's self-administered checklist consisting of 9 questions. A PHQ-9 score of 11 or above is very sensitive, 89.5% specificity and 77.5% sensitive, 89.5% sensitivity and 77.5% specificity. Well, this is the PHQ-9. It's modified for adolescents, but it's essentially the same thing. It's just the words that were modified. It consists of 9 items, and there are 4 columns that can be checked. If, for example, the question, how have you been bothered by each of the following symptoms during the past 2 weeks? Like feeling down, depressed, irritable, or hopeless. If the person checks, let's say, column, the third column, which is 2, that's counted as 2 points. If in the second question, little interest or pleasure in doing things, checks the last column, that's counted as 3. So quickly you have 5 points. And it goes down the line, underscoring the different symptoms of depression. Number 9 is very important, and we will see why that's very important. Positive, like we said earlier, is a score of 19 and above. But if the question number 9 is checked with column 1, several days, or column 2, or column 3, then assume that you need to assess for suicidality. And so that's when you move to the screening for suicide, the Columbia Suicide Severity Rating Scale. Again, there are 6 questions here. Number 1 and number 2 are very important. This is the gold standard in suicide. This is designed for use by health workers who have had no specialist mental health training. And it allows for a stratification of risk and treatment planning, which I will explain later. So, the first 2 questions are very important. Wish to be dead. Have you wished you were dead or wish you could go to sleep and not wake up? If the answer is yes, we can go all the way down to 6, to item 6. Suicidal thoughts. Have you had any actual thoughts of killing yourself? If it is yes, then we complete the whole thing. On the other hand, if no to the 2 questions, then we jump to 6, which is about, it's like a double check. Have you ever done anything, started to do anything, or prepared to do anything to harm yourself? So this is what it is, This is question number 1 and question number 2. And this is question 3, 4, 5, 6. And they are rated with color coding. Yellow is mild, orange is moderate, red is serious, severe. And so when you code them with these colors and you end up with this is how we go. We see here the severity of level and the intervention needed. In a mild case, if your assessment indicates mild, with the student, do safety planning and advise parents for close observation. We have to notify the parents or legal guardians about the risk level. It's mild, but we have to keep a close observation. And should we refer to mental health professional, we can opt not to refer immediately, observe, and continue some counseling, maybe with a guidance counselor or with some psychologist counselor. Now, if in your assessment it's moderate, with the student, we start the safety planning and close observation, but with the parents, we say, remove all possible objects that can be used to harm the young person, that the young person can be used to harm himself. There is no emergency referral, but maybe a referral to mental health professional should be effected. However, if your rating is severe, then you do safety planning with the student or the young person, and we'll talk about that in a little while. While we will notify the parents, again recommend removal of all objects that can be used against oneself, and then emergency referral or bring to the emergency room for either hospitalization or quick intervention. Now, when we interview the young person, he should be interviewed separate from his parents. And we have to take very good care in our interviewing posture, that we are patient for him to share sensitive mental health concerns. He has to feel that we are sympathetic and we understand his situation. More detailed questions can be asked later when he's more comfortable with the CSSR. And initial questions should be open-ended and non-threatening. These are some of the examples of the questions we can ask. I have noticed that you scored positive for depressive symptoms in our PHQ. When did you begin feeling this way? That's a close-ended question. Can you tell me more about what you have been feeling lately? That's an open-ended question, meaning it's rich for further discussion. Now, confidentiality must be assured, but with a reservation that if you are at risk for harming yourself or others, then your safety takes precedence. So I will have to break confidentiality and tell your parents about the risk. The physician should then inform the parents and guardians when they believe that the patient is at risk, even if it is against the patient wishes. Pronouncement of suicidal thoughts should never be dismissed. We have to take them seriously until proven to be otherwise. We have to know how to give empathetic statements like, you must really be suffering deeply for you to even think of hurting yourself. Reassure the patient's cry for help, that he has been heard. And again, some empathetic statements. I'm giving some examples. I may not understand fully how you feel, but I care about you and I want to help. Inform the patient the need to tell the family in order to facilitate a plan of treatment. And you can go back and say that I promise you confidentiality, but remember I told you that if you are at risk of hurting yourself, we will have to inform your family about your suicidal thoughts. But we will talk only about your suicidal thoughts. I'm not going to talk to them about your girlfriend or what happened to you and your girlfriend. It will be focused on how to help you deal with this depression and suicidal thoughts. Safety planning with the patient. This is a systematic approach to maintaining safety of a suicidal patient. It may take about 20 to 45 minutes sometimes. It's a collaborative work with the patient. The goal, of course, is to provide patients with specific strategies and support so once suicidal thoughts arise. And this is a template of a safety planning. Number one, help the patient recognize and list down. He has to recognize the warning signs. What are the thoughts, mood, behavior, or situations that you associate with suicide? The patient, the young person may write there, for example, a sad music or suicidal thoughts that will trigger me to commit suicide. Let him keep it there because he has to keep this template with him and pull it out in times of danger. We need to help him identify internal coping strategies. What can you do on your own to cope with suicidal thoughts? If you're having suicidal thoughts, what can you do? He may write, I'm going to call my best friend. I'm going to call my counselor, but he has to write it down there. Help him identify social contacts that can help uh, put his mind away from his suicidal thoughts. Who can you call or where can you go to distract yourself from suicidal thoughts? I'd like to talk to my best friend. Maybe I'll be talking to my girlfriend or my boyfriend. But he has to write it down there. Enumerate the people that will help resolve suicidal crisis. You're having this suicidal crisis right now. Who do you think can help you get over this suicidal crisis? Maybe the parent, the teacher, but he has to write it down. Identify mental health professionals or agencies that he can contact. Who are the professionals you can contact during a suicidal crisis? He has to write the name there, and you may have to help him name some places like the National Center for Mental Health or the Philippine Mental Health Association or PGH, emergency room, or any person, your friendly psychiatrist, give the name and telephone number. Now, reducing the potential lethal means, how can I make my environment safe? Let him write down there. He may write, I'll tell my mom to remove all her medicine from the medicine cabinet because every time I pass by there, I feel like taking an overdose of her medicines. Or remove all harmful objects in the kitchen. Informing the family regarding the suicide risk and the plan of action. It is important to emphasize that suicide is a medical emergency and depression is a medical illness. Explain the neurobiology of depression. It's very simple. We all know that we have billions of cells in our brain, but no two cells are touching each other. There is a space we call the synaptic cleft. And the cells are connected by certain chemical substances in the brain that we call neurotransmitters. And at bottom, when these neurotransmitters are off balance, then all kinds of psychiatric problems can happen, including depression and suicide. So you can simply say that there is an imbalance, in these chemical substances very important in the brain. And you may need to take certain medicine to bring back that balance. This is simply to emphasize that depression is not just all in the mind, it is also in the brain. Discuss some psychosocial perspectives like the cognitive distortions in the patient's view of himself, view of others, and view of the future, resulting in changes in his behavior and current thinking. Depressed patients usually is very negative. He views himself or herself as hopeless, nothing will ever happen, nothing good will ever happen. I'm better off dead. Everybody will be happy if I am dead. The future, I don't see any future for me. So these are all cognitive distortions. Informing the family, be calm, be aware of your own reactions. It's not easy to talk to the family that your son or your daughter is suicidal, but it is something that we need to do. Be mindful of our own emotions and reactions. But the point is we have to communicate the seriousness of the situation and reassure the parents that there is treatment available and ensure safety at home. Remember the safety planning. Remove all items in the household that may be used against oneself, like firearms, medications, alcohol that will cause disinhibition. Make sure that there is someone who's keeping close contact with the young person at home. Well, now, we never wish we should ever talk about suicide to anyone, but it has become a common reality in our lives now. And as doctors, it's almost impossible to always be able to avoid it. So I'm very glad that we're talking about this and hoping that with this conversation, you will open your mind to the possibility of talking to someone who has certain suicidal thoughts. These are some of the references that I use. And with that, thank you very much for listening.
Thank you, Dr. Banaag, for that very informative talk.
Kumusta po kayo? In these trying times, we may find ourselves coping and trying to find our bearings. Amidst the cyclic and repetitive lockdowns and the mandate to stay at home, away from social and religious gatherings, and particularly the people we need to protect the most against the disease, it is not uncommon to feel sad, stressed, confused, scared, or maybe even angry at the situation. For those of us in the medical profession, we know that it is normal to feel this mix of emotions. However, for those who are not, we can only imagine how hard it can be. Let us not forget to check in on our loved ones, especially those who are walking ahead of us in life. Our senior patients, our seniors, our elderly loved ones. The few minutes that we spend checking in on them may be through a simple video call may help lift their spirits, as they may be feeling lonely and isolated and need to be followed up to make sure that they are eating well, staying active, and adhering to the medications they are on, as well as keep us in tune when they need medical attention. Virtual gatherings, such as a virtual Noche Buena discussions, are a great way to cross distances and maintain our yearly traditions without putting them at risk for the disease. As we forge our way into the future, may we always remember, no matter how physically distant we may be, we can remain socially and spiritually connected and present with our loved ones all of the time.
We will now be moving on to the next lecture, which will be on anxiety and depression in the elderly. Dr. Pia Natalia T. Reyes Sia is from the UP College of Medicine class of 2002. She did her residency training in adult psychiatry at the State University of New York Health Science Center in Brooklyn, Kings County Hospital Center from 2003 to 2007, where she served as chief resident on her last year. Her current designations are as follows: courtesy staff with special privileges at the Department of Psychiatry of Manila Doctors Hospital, associate active consultant at the Department of Psychiatry of Makati Medical Center, and visiting staff at the Department of Psychiatry of the Medical City.
Thank you very much for your kind introduction, Dr. Protasio, and I would like to thank the organizers of the UPMAS Symposium for inviting me to talk about these very important topics in geriatric psychiatry, which are depression and anxiety in the elderly. The following are my objectives. I will be discussing epidemiology, risk factors, red flags, how to intervene, and the management. In the interest of time, this discussion pertains only to cognitively intact older adults. We do need to keep in mind the following ideas when discussing anything about the elderly. The elderly population is the most heterogeneous in the whole lifespan. Unlike 10 babies who will all have pretty much the same issues and problems, you can have 10 elderly with wide differences in the state of health and functional ability. There is less research on the elderly versus younger adults, although there are more research now than before. There is also more research on depression in the elderly versus anxiety in the elderly. Depression and anxiety often co-occur in the elderly. Why is it important to learn about depression and anxiety in the elderly? Depression and anxiety impact quality of life of our elderly. Their presence worsens the state and the prognosis of comorbid medical illnesses and independently increases caregiver burden. Let us first look at the epidemiology of mental disorders in the whole population. It is generally accepted that mental disorders that fulfill criteria are less prevalent in older adults compared to younger adults, not including the neurocognitive disorders, of course. In this slide, the topmost bar represents the prevalence of psychiatric disorders in over 65. And as you can see, it is the smallest bar in all of the categories and mental disorders. If you look closely at the generalized disorder segment, it is the one which has the most similar prevalences among the different age groups. And that will explain my next slide that says that the exception to the rule that mental disorders tend to be less prevalent in older adults is GAD, which maintains similar prevalences rates in the young and in the old. The prevalence rate of late life depression in the community ranges from 2%, but in clinical settings, this can be over 30%. In older adults, subthreshold depression was generally at least 2 to 3 times more prevalent than major depression. In the Philippines, a cross-sectional survey of a random sampling of older adults in Rizal province estimated depression at 6.6%, but could be as high as 26.5%. Anxiety disorders in community samples can be as high as 15%, with subthreshold anxiety going as high as 56% in clinical samples. GAD is the most common anxiety disorder in the elderly with a prevalence of about 11%, followed by specific phobia at about 10%. Fear of falling is not a formal diagnosis in the DSM-5, but can be as high as 65% and even higher for those with a history of falls. Panic disorder, as a comparison, has a prevalence of 2%. So what happened to our elderly during COVID as compared to before COVID? This is a rough comparison of published data regarding prevalence rates of depression and anxiety around the world. And you can see that the experience of each country is very different from one another, which may be associated with that country's experience of COVID, along with cultural and even political factors. For example, in the US, despite having the highest COVID numbers, it seems that both depression and anxiety became less during COVID compared to pre-COVID. In Spain, on the other hand, we can see a clear increase in the prevalence. Israel is the same, having a slight increase like with Spain. And China seems to have a higher increase in general for both depression and anxiety. And lastly, Greece has the highest rates for depression even before COVID, which even doubled during COVID. Unfortunately, I could not find any published data on Philippine elderly during the COVID period. In this very long and comprehensive list of risk factors associated with late life depression, I will be highlighting the more acute risk factors, the not so usual risk factors, and the easily forgotten risk factors that can be modified. Changes in marital status and living situations and recent spousal bereavement are important risk factors to keep an eye out for. Caregiving activities for disabled or ill family members and low social support and social network are risk factors that can be modified and therefore should be asked about. In patients with late life depression, life events precede the depression in more than 50% of the time. Subthreshold anxiety is strongly related to subsequent development of major depression among older adults. It has been suggested that if anxiety is present in a geriatric patient, it should be considered as a sign of depression. Smoking and heavy alcohol consumption, a high inflammatory content diet, and obesity are lesser known risk factors for late life depression. Medical problems, particularly pain, substantial physical impairment, sensory deficits, and chronic medical conditions are risk factors for depression. And so we must keep in mind that these can be modified to some degree with physical therapy, audiology and ophthalmology referrals, the use of hearing aids, and other interventions such as those. Interestingly, lower levels of residential greenness, poor quality of urban residential built environment, long-term exposure to ambient fine particulate matter, and exposure to natural disasters, all of which are very common facts of life living in urban areas in our country, are also risk factors for depression. There is a shorter list for risk factors for anxiety, and it overlaps considerably with depression risk factors, except for the following: parental loss or separation, low affective support during childhood, as well as a history of mental problems in the parents. I have seen in my clinical practice that family members most commonly complain about their older adults as having walang pake, walang interes, and walang motivation. They also complain of non-specific somatic complaints, and very often this is the only complaint. Forgetfulness is also a common complaint that can be a red flag for depression, and also having many worries. In our setting, family members are often a good source of information as regards their older adults' mood. Please screen and don't rely on red flags. The U.S. Preventive Services Task Force does recommend screening for depression in the general adult population, which of course includes the elderly population. Older adults can be screened for depression using an instrument such as the PHQ-2, the PHQ-9, the Cornell Scale for Depression in Dementia, and the Geriatric Depression Scale. When screening is positive for possible depression, the diagnosis should be confirmed using criteria from the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5. This is how the PHQ-2 looks like. It only asks 2 questions. Over the past 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, and feeling down, depressed, or hopeless. A score of 3 or more is considered a positive result. Red flags for anxiety in older adults can include being nervioso, nerviosa, because they will readily identify to this, parating pagod, and problems with sleep, which turn out often to be associated with generalized anxiety disorder. Unfortunately, both older adults and clinicians mistakenly view anxiety as a part of the normal aging process. One of the ways to screen for generalized anxiety disorder would be to ask, are you a worrier? And if yes, is it hard to stop the worrying? One way to screen for specific phobias would be to ask, are you afraid of blank? And just fill in the blanks. It is best to ask directly about the fear of falling. I have included other screening questions here for other anxiety disorders for your reference. The presence of the following symptoms are signs of serious mental illness and is a reason to involve a mental health professional for collaborative care as soon as possible. These are psychosis, confusion, suicidality, malnutrition, rapid cognitive worsening, worsening function, difficult to control blood pressure, and pain syndromes, especially if vague or unresponsive to usual care. Because new onset panic disorder is relatively infrequent in older adults, any new onset panic disorder in late life should prompt a thorough search for alternative and comorbid diagnoses with close attention to systemic medical conditions and medication side effects. Intervention starts with the need to do a comprehensive geriatric assessment. This consists of the systematic evaluation of an older patient's functional and psychosocial status and medical conditions. It places a special emphasis on the patient's ability to perform daily activities and on the quality of life. Common pathological conditions affecting older adults should be kept in mind, including cognitive impairment, impaired mobility, falls, incontinence, and polypharmacy. Speak to and involve family members or caregivers in the assessment. Telepsychiatry considerations for geriatric patients are similar to those for adult patients with a few key modifications. Pre-visit accounting of general events and the patient's attitude, comments, complaints, utilizing as many sources of information and household observations would be useful. I have the family or caregiver fill out forms ahead of time if necessary and have these emailed to me before I see the patient. The clinical examination may require a household member's assistance, particularly if the patient is delirious, combative, or agitated, and having poor hearing or poor vision. For the physical examination, camera control at the far end with an easy wide angle close-up and focused viewing to detect tremors would be useful and to detect other things like micrographia and other psychomotor symptoms. Sometimes household members can be trained to check for extrapyramidal side effects like cogwheel rigidity. I asked the family members ahead of time to prepare a camera that can be moved around so that I can see the patient walk, stand, and do other movements like the rotation of the wrists. In the primary care setting, a stepped care approach has been recommended. In cases where the patient is screened for mental disorders and falls short of fulfilling the criteria, but the index of suspicion is high, increasing the frequency of follow-up and watchful waiting can be helpful to decrease morbidity of the mental illness. So if there is only mild illness or subthreshold symptoms, then psychoeducation, active monitoring, and behavioral activation in the form of exercise and increased social interactions may be enough. If the psychotherapy is accessible and the patient is interested, this should be done. In the case of moderate illness, it would be necessary to start pharmacotherapy. Psychotherapy is effective for late life depression, but the magnitude of the effect varies widely with the type of control group. Psychotherapy is not as readily available as pharmacotherapy, but is considered first-line treatment here as there are less side effects. With a greater use of telemedicine, there may be more availability of this treatment modality. As for the psychotherapy of late-life anxiety, it appears that medications are more effective than CBT. The studies supporting the efficacy of CBT versus supportive therapy and waitlist control have mixed results. In elderly persons, the most effective ingredient of CBT may be relaxation techniques. Mindfulness-based stress reduction and acceptance and commitment therapy approaches show promise, but they require further validation on larger samples. Recommendations for pharmacotherapy in the elderly are usually extrapolations of findings from middle-aged adults. Keep in mind that elderly patients are more susceptible to drug-induced side effects, urinary retention, delirium, cognitive impairment, orthostatic hypotension, and sedation. Elderly patients have changes in both pharmacokinetics and pharmacodynamics due to diminished glomerular filtration, reduced hepatic metabolism, decreased cardiac output, and changes in the density and activity of target receptors. The evidence base for older adults is limited and consists mainly of several small clinical trials. Many are not recent and are in mixed populations. If you do plan to give medications to treat anxiety or depression in the elderly, please remember to start low, go slow, but keep going to reach the target minimum effective doses of the medication. I have listed here the published studies that are specifically for late life depression, and as you can see, it is not much. After a clinically experience-based risk-benefit analysis, I use escitalopram as first line. However, as seen on the slide, there exists evidence for venlafaxine, paroxetine, desvenlafaxine, duloxetine, and vortioxetine. Tricyclic antidepressants, despite a particularly good evidence base, is not considered first line because of its many side effects that are difficult in the elderly. In addition, a meta-analysis comparing it with SSRIs do not show a difference in effect. There may be a role for quetiapine XR for monotherapy, but again, this is not considered first line. Consideration for SNRIs and other classes of medication will be discussed in the following slides. As for anxiety, there are even less studies done specifically for late life anxiety, but SSRIs are still considered first line. There exists evidence for sertraline, venlafaxine, duloxetine, pregabalin, and quetiapine XR to be effective for late life anxiety. SNRIs and SSRIs are relatively well tolerated, but clinicians should assess the potential risks of SSRIs in the elderly population, including gait impairment, increasing risk for falls, GI bleeding, bone loss, and hyponatremia. The goal of using benzodiazepines is for the management of insomnia in depression or anxiety symptoms in the short term, while the antidepressant is being given time to take effect. In the elderly population, the risks often outweigh the benefits and they need to be used with caution. Benzodiazepine use can lead to falls, hip fractures, and cognitive impairment. More recent studies have found possible links between benzodiazepine use and dementia. My clinical advice, please don't start unless you know how to stop. So in summary, more adults will have anxiety disorders than depressive disorders. However, depression and anxiety frequently co-occur. Findings are mixed as to COVID affecting the mental health of the cognitively intact elderly. I mean, the COVID pandemic in general. Depression and anxiety risk factors overlap, but the more commonly established risk factors are being female, recent adverse life events, having chronic physical conditions or illnesses, and a history of mental health disorders. Rather than rely on red flags, please screen for depression and anxiety using a few simple questions. A comprehensive geriatric assessment is the first step to intervention, and a stepped care approach is recommended. Although there is evidence that psychotherapy is useful, it is not readily available in our setting. There are mixed results as regards psychotherapy for anxiety in older adults. In the case of moderate illness, it is often necessary to start pharmacotherapy. Pharmacotherapy in older adults are often extrapolated from findings in midlife. However, pharmacotherapy is effective in the treatment of depression and anxiety in late life. Please keep in mind that older adults are more susceptible to side effects and have a different pharmacokinetic profile from younger adults. In general, start low, go slow, but keep going. Thank you very much for your kind attention.
Thank you, Dr. Reyes Sia, for that wonderful lecture. We will now proceed with the open forum. This will be moderated by Dr. Lorene Conanan, Associate Active Staff of the Department of Psychiatry of Davao Doctors Hospital, and Dr. Lorenzo Maria de Guzman, Research Associate of the Neglected Tropical Diseases Study Group of the UP National Institute of Health and Doctor to the Barrio Batch 36.
Maayong hapon po sa lahat. Good afternoon
Good
po.
afternoon. Hi, sir. Hi, ma'am. Okay.
Right po. Beginning po with the first question po for Dr. Banaag. Good afternoon po, sir.
Good afternoon.
With the increasing prevalence of mental health problems, should the parents also need to undergo mental health evaluation po? No? The increasing prevalence of mental health problems, should the parents also need to undergo mental health evaluation?
Well, it is. Whether we should do parents' mental health evaluation separate, it's hard to do that. When they bring their children, it's our common practice to have a sense of where the parents are. A lot of times, it's not always fault of parents, but a lot of time, parents may have difficulty handling the young person and may aggravate the depression or anxiety. And so we work closely with parents. We have to make assessments of where they are and how we can help them.
All right. Thank you po, sir. I think for our next question po, Doc Lorene, first question po for Dr. Reyes naman po. Yes po. I think I read na lang po muna. No? You cited
Sana okay lang.
Yes po. All right po. For Dr. Reyes-Sia, you cited prevalence rates of anxiety and depression in other countries. Do we have rates among Filipino patients? And among Filipinos po, what are the specific factors that may contribute to depression and anxiety?
Okay, so let me first say that I think the study is underway. Please correct me because it's actually based in UP. The studies regarding the epidemiology for all the major mental health disorders is underway now. So we actually don't have data aside from for Filipinos, okay, in general. So, but my talk is on the elderly. So that particular study that I cited in 2011 That was just, I think, a poster at a Geneva Convention. So we don't have data right now regarding the elderly, any rates prior to COVID or even during COVID. It would be nice. It's a study waiting to happen. So I hope somebody does it. Okay. Are there cultural factors? Are there certain risk factors that are present for the Philippines? Don't have that data. However, I will say that because worldwide it does appear that the elderly have a lower incidence of mental health disorders, it's going to be harder to find risk factors for those. Because just to pick them up from the population will be hard. And then trying to narrow it down from there, that's going to be even harder. I hope we get that data, but so basically right now there isn't any. Okay. So I hope that answers the question.
Right po, thank you po. The next question po.
There is a question here. I am a parent and I think my child is depressed and anxious. What are the first steps I can do to address the problem? And where do I go first?
Well, the first step, I think, is for you to talk to your child. You know, every parent should be sensitive to the state of emotion of your child. You sense. Kumbaga parang may fever, hinihipo natin, you know, but when they look sad or they look irritated and angry, let's not drive them away. Let's not say, pahinga ka na lang sa kwarto mo, you know. Let's talk to them. And just start by saying, parang iba ang nakikita ko sa iyo ngayon. Ano ba nangyayari, anak? You know? Para kang walang gana. Malungkot ka yata eh. Is anything happening? You know? Wala, mami. Wala lang. You know? Alam mo na, mga bata, they really don't want to talk to their parents about those kinds of problems. And so, the parents can follow with, you know, anak, I'm here. I want to help. If you think I may not be able to do anything about it, and you might be right, there are people we can talk to, you know. We can get in touch with certain people. So there are people that one can talk to. So,
good afternoon.
sandali if in Davao, for example, you have two child and adolescent psychiatrists, and many of the adult psychiatrists also handle these problems, you know. So I think the first thing is for the parents to talk to the child and then look out and see what references can be made. I'm thankful that in many places in the country now we have enough psychiatrists, even though very few. We have two child and adolescent psychiatrists in Davao. We have one or two in Cebu. So meron na rin naman. And the Philippine Psychiatric Association, you just look for Philippine Psychiatric Association in the website. We have an organic directory that will tell us where the child psychiatrists are all over the Philippines. So, but the first step is talk to your child. Be sympathetic, be more understanding, and then offer a referral to someone, maybe even a counselor in the school.
Thank you for that.
Yeah.
In addition to that, beyond the home, there is also a question here that I am a teacher. I suspect that the student is depressed and suicidal. What should I do? So yeah, this is quite relevant also because it's also teachers who are the first line.
Well, teachers serve like second home. School is like a second home, and teachers are like second parents. The Philippine Society for Child and Adolescent Psychiatry has a module that we will be running soon for teachers because of this very situation. Now, the teacher should take a deep breath. Many teachers are not ready for these kinds of problems. Take a deep breath. Talk to the child. If you see that the child is depressed, anxious, looks quiet there in the corner, I think you should take one step further. And when everybody else goes out, say, can we talk? Can you stay for a bit? Let's talk. What's going on? You used to be more happy. I used to see you laughing with your friends, but now I notice this change. Something must be happening. Uh, you think we can talk about that? You think maybe we should talk to your counselor? You connect them to the counselor. Every school is supposed to have a counselor, at least one. That's not always true. But if there is a counselor, then the teacher can connect to the counselor and also inform the family. I think it's the responsibility of the teacher to connect to the family and inform them that they're noticing some behavior in the child that may cause alarm. And both family and teachers should help to look for resources in the community.
Thank you very much po, Doc. Now we move on for another question for Dr. Reysia po. Is it all right to take Rivotril po for a long period of time? And related po dito, what is the caveat for people who self-medicate with Rivotril po? And I think pero moving forward na po, what are the common relaxation to teach po for elderly po?
Okay, so there's the Rivotril question. All right. Dr. Banaag, I saw was already reacting. Rivotril is a very effective medication for anxiety. All right, let me start with that. Unfortunately, it is not really good for long-term use. Studies show that after 6 months, there is already a developed physiologic dependence on the Rivotril, and so not only will you have so in other words, if you were to remove a benzodiazepine like Rivotril after 6 months on a patient, the anxiety would not just return to where it was before, there would be rebound. So it would be actually, you'll end up with worse anxiety. And that's why we don't like to give it long term. Because then every attempt at removal, for whatever reason, will be met with a lot of resistance. So is it good to be taking it? Studies out there are showing more and more that use of Rivotril does add to the risk of dementia. So that's something a lot of people are afraid of. And it makes sense given the pharmacodynamic profile of Rivotril, what it's supposed to do. It's not very strong though, okay, the evidence yet pointing to dementia, because dementia is such a complicated illness. But for those who would like to decrease that risk, because it's very important to them to remain cognitively intact when they're 80 or 90 years old, it may be best not to be using benzodiazepines for long durations of time. Okay. Going into the geriatricians, if there are anyone watching, will also talk about not just cognition, but the risk of fall, right? The risk of fall and the risk of confusion with benzodiazepines, which is very high. So even in the Beers criteria, which is a whole list of medications that geriatricians sort of refer to say which is appropriate versus inappropriate in the elderly, benzodiazepines is number one. Okay, that's inappropriate. So we don't like to give it. Okay. Going into the relaxation techniques, one of the most effective would be the breathing techniques. I think there's a 4-7-8 square. You breathe in for 4 seconds, hold it for about 7 seconds, then breathe out for 8. There are different variations of this. The most effective will always be that the breathing out is always longer than the breathing in. Okay, and doing it just 10 times will already reduce anxiety. That said, many YouTube videos are helpful for relaxation. There is something also called progressive muscle relaxation, which is one of the cornerstones of behavioral techniques in CBT. That's also available via, YouTube. Some therapist is talking and putting you in a relaxed state. That's also very helpful for everyone, including the elderly.
Can I say something about that? Because we encountered that in child and adolescent psychiatry. Parents ask, what can I give if he's nagwawala? Paano ba yan? Teenager neto, nanununtok ng kanyang wall. He's hurting his hands. Is there anything we can do short of strapping him? So Rivotril is, as you said, Pia, it's good, but the danger is long-term use. As PRN, yes, it's helpful to answer certain emergencies. So I also prescribe it, but as a PRN medication. Ang danger kasi with prolonged use, yun nga merong tolerance. Kumbaga parang alcohol, you drink beer now, 1 bottle gives you the buzz. After 2 weeks, you need 2 bottles. After 4 weeks, you need 4 bottles. Ganon din ang nangyayari sa mga benzodiazepines. And so after a while, they get dependent. Sometimes they say psychological dependence. Sometimes I feel parang physical dependence din. But it's very helpful if we can be very firm in saying, I will prescribe you this, but you will use this only for PRN as needed during emergency or urgent situations.
Right po. I think we have time for our last question po. Are there particular trends and phenomena po that predispose children and adolescents nowadays for Dr. Banaag po and for Dr. Arecia po or elderly po to depression and anxiety? And as the younger ones, how can we have provide a supportive environment po for them now po?
The restrictions that this pandemic has imposed on all of us is a formula for depression and anxiety for the young people. When you are young, we practice and exercise our ability to relate to other people. We establish friends. To do that, you have to go out. When you're a teenager, you want to assert your growing independence, a sense of autonomy, and more importantly, you are working out your own sense of who you are. We're establishing our sense of identity. And you cannot just get that staying at home. These are very important developmental tasks at these periods of life. The young person has to be with his peers. He has to talk to his teachers. He has to develop, heroes of other adults other than his parents. And so they need to go out. But the pandemic keeps us from doing that. And so they sulk, they cry, the kids keep crying and say, when I'm going to see my friends, why can't I visit my friends, So yung mga developmental tasks that needs to happen at this point are actually being blocked by the restrictions of the pandemic. So very formula na siya for anxiety and depression. Hindi naman lahat nadidepress with clinical depression. Malungkot, In fact, there's a new word, not really a new word, but the word floating around is, we are all languishing. We're all languishing, all of us. We're not really depressed, but we're not happy. Everything is so uncertain. We don't know what we're waiting for. We want to do more, but we cannot. So we sit around, we try to entertain ourselves, but we can only do so much. After a while, we feel like we're languishing. This is now a word that's very commonly used. This is not a psychiatric diagnosis. This is a very human reaction, But we're all waiting for the end of this pandemic. And this the kids are very, very much affected by this. So what can we do? What can parents do? First, parents have to understand the developmental needs of their young people and how these are getting frustrated. Second, they need to provide some activities, you know. Of course, a common battleground is the games, you know, electronic games. Walang magawa na yung mga bata, lalo nang na-engage sa electronic games. I will not stop them, but I will say, anak, there are limits. Why don't we read? Why don't we talk, walk around you if allowed? There are times naman na allowed naman tayong maglakad, you know. So take a walk, take your pets for a walk, buy pets for your kids because they are good companions. They are good to exercise their need to attach to someone, to develop relationships, you know. In fact, we also use pets for therapy now, you know, dogs, cats, you know. So maybe see a movie, and whenever possible, maybe just drive around and say to the kid, we'll drive around, but we're not going to get out, you know, we'll just stay here wherever it's allowed. At least drive around for a change of scenery. And take out some food, some new food, and bring it home, you know. Anak, ano, special order mo, bili na tayo. Take home na lang, ha? Hindi tayo pwede ron sa loob. So, we can do a number of things. We need to be a bit more imaginative. But we need to be mindful of the needs of our children. Don't get angry when they are getting fretful. It's because they're so frustrated. The developmental needs are not being met and in fact being blocked, you know. So parents should be very mindful of that and be more sympathetic with their children. Pag nagwawala, wag mo naman paluin. Hawakan mo na lamang and say, anak, we cannot solve problems this way, you know. Pareho lang tayong maiinis. Halika na, magmerienda tayo. Mommy prepared some food. Merienda na lang tayo, anak. And let's talk while we're having merienda. In other words, have some creative ideas on how can you diffuse those moments of intensity because they are so frustrated with all the imposition of this pandemic, which are necessary for our survival. What I usually tell the kids, even the ones that I see in the clinic, is say, well, we have to realize there is a war. There is indeed a war. It's a global war. Ang sinasabi ko sa kanila, maswerte na rin tayo, pandemic ng COVID, pwede pa tayo at meron tayong technology ngayon, we can reach out, you know. Pero kung ito yung giyera na may mga bala, bomba, magtatago tayo sa ilalim ng lupa. So let's be grateful with what we have now, you know. This allows us connectivity still. And I will encourage my kids, the kids, get in touch with your friends, you know. Call them up. You have the techniques, we have the technology now. So get in touch. And many of them do get in touch. There are now apps that they can even watch movies together and then comments together and laugh together. So we need to facilitate that. Parents will have to be mindful of the frustrations of their children because their developmental needs are being blocked. Sorry for the lecture. I get impassioned by that because I feel sorry for a lot of kids. Reminder sa mga parents.
Do we still have time for me to answer or ano? Okay. So even before the pandemic, lack of socialization was already a big problem for the elderly.
Yeah.
Because they were already pretty not mobile. They are very less mobile than regular adults. So that is one thing that has a positive and negative actually during the pandemic. So on one hand, those who were very mobile before are now not mobile anymore because of the quarantines. On the other hand, those who are not mobile now have all their children around them, right? They have the children, they have the grandchildren, they have the nieces because now they are under quarantine with them. And so there will be a subset of elderly that's actually doing pretty well.
Yeah.
And there is a subset of elderly who will not be doing well at all. So what can we do to help prevent this? So same thing as Dr. Banaag would say, really we need to communicate, we need to keep in regular touch with our older adults, the people we love in our lives. It may be worth really investing more time in talking with them now, because perhaps we were not in the habit of talking with them before, maybe because of a stoic culture in our, na hindi sila nagrereklamo, and so therefore you think nothing is wrong, but actually there is something wrong. And so we really need to kind of invest the time. And in some cases, I do recommend that maybe you should quarantine now with your elderly person. Make the decision to move in with them, or make the decision for them to be moved in with you if you are really concerned. And if we have evidence that things are not well, I will say that more of the elderly patients that I see, they're more anxious than they are depressed. Okay. And there are also more people who are worsening in their dementia rather than depression. Okay. So I actually don't see a lot of depressed elderly at this time. It's really the anxious and the worsening dementia. That's what I see. Yon. So what can we do? Okay. So number one, always for the elderly, I always recommend, please exercise, because we do not want this pandemic to lift and then you cannot walk na pala. Okay, so what's the point of coming out of quarantine if you cannot walk, right? So please exercise daily. That's going to help. There's a question in the chat box, like what to do. Behavioral activation, that's what it really means, the exercise. So I recommend as much as possible 30 minutes of exercise every day. Okay, actually they only recommend like 6 days out of the week, but I would say every day, if you can, some kind of activity. That's part of it also was part of the lecture earlier. Please maintain a good diet, expose yourself to the sun every once in a while so we get enough vitamin D. And lastly, the socialization. We can be very creative as regards the socialization. We had people writing about playing games over the internet, reading stories to grandchildren via Zoom, playing card games, playing charades, playing any sort of funny thing to help with socialization because of the pandemic. That ends my answer for that.
Thank you very much po, Dr. Banaag and Dr. Reyes for the wonderful and informative discussion. Hopefully, this will help us and our patients be less bluer than blue this coming holidays po. Turning you over to our chair and co-chair, Dr. Magnaya and Dr. Roa, to wrap up the session.
Thank you to our speakers and moderators for that fruitful session. We will now proceed with the awarding of certificates. We would like to award the Certificate of Appreciation to Dr. Cornelio Banaag Jr. in grateful recognition for his invaluable contribution as speaker in our session entitled Bluer Than Blue, Addressing Depression and Suicide in Adolescents during the UP College of Medicine Grand Scientific Symposium. The Certificate of Appreciation is given to Dr. Pia Natalia Reyes-Sia in grateful recognition for her invaluable contribution as speaker in her session entitled Anxiety and Depression in the Elderly during the UP College of Medicine Grand Scientific Symposium. We would also like to award the Certificate of Recognition to Drs. Lorene Conanan and Lorenzo Maria de Guzman for their contribution as moderators for the focus session on mental health given this 23rd day of September 2021, signed by Dr. Maria Assumpta Cecilia R. Serrano, President of the UP Medical Alumni Society Davao Region and overall Chairman of the Organizing Committee, Dr. Teresa Luisa G. Cruz, Director of the Postgraduate Institute of Medicine, Dr. Charlotte M. Chong, Professor and Dean of the UP College of Medicine, and Dr. Lara Teresa Alantahan Naleta, President of the UP Medical Alumni Society. Thank you, doctors. Let us now proceed to our next focus session on cancer prevention, chaired by Dr. Arthur Gregory A. Lui, an internist specializing in thoracic and GI oncology.
Good afternoon, everyone. Thank you again for joining us. This is our sixth focus session. Our topic will be on cancer. My name is Arthur Gregory Louis. I will be your session chair and moderator. Later in the live Q&A, Dr. Terence Lincoln T. Kua will also join us during the program. This session will have two parts. The first part, we will be discussing background and updates on the National Integrated Cancer Control Act, that's the NICA law, and the National Integrated Cancer Control Program, NICCP. We'll discuss the objectives, composition, and function, alignment to the existing quality healthcare system, the patient support programs, and discuss the role of the specialist and the primary care physician. Our speaker is Dr. Corazon A. Ngelangel. The second part will be a case-based discussion on breast cancer. We will discuss the epidemiology of breast cancer in the Philippines. We'll discuss risk factors, signs and symptoms of breast cancer, diagnostic algorithm in patients presenting with a breast mass, treatment modalities for breast cancer, and of course, discuss the current gaps in screening, diagnosis, and management of breast cancer. We will be joined by our panelists, our medical oncologist, Dr. Michael San Juan, our surgical oncologist, Dr. Siti Aneza Camille Maglangit, and our radiation oncologist, Dr. Faika Bagis. So to start, I'd like to turn over now the virtual stage to Dr. Corazon A. Ngelangel.
Our speaker for this session is medical oncologist Dr. Corazon A. Ngelangel. Dr. Ngelangel graduated from the UP College of Medicine in 1979. She did her residency training in internal medicine and her fellowship in medical oncology at the Philippine General Hospital. She is currently the director of the Asian Cancer Institute at the Asian Hospital and Medical Center, professor emeritus at the UPCM, and member of the Philippine Cancer Council for NICCA.
Greetings to all, and thank you for this opportunity to share with you the current progress of the National Integrated Cancer Control Act. RA 11215 policy declares an integrated and comprehensive approach to health development, which includes the strengthening of integrative, multidisciplinary, patient and family-oriented cancer control programs, policies, system, intervention services at all levels of the existing healthcare delivery system. Towards this end, to prevent cancer and improve cancer survivorship by scaling up essential programs and increasing investments for robust prevention of cancer, better screening, prompt and accurate diagnosis, timely and optimal treatment, responsive palliative care and pain management, effective survivorship care, and late effects management and rehabilitation. To make cancer treatment and care more equitable, affordable for all, especially for the underprivileged, poor, and marginalized Filipino. This act was signed by President Duterte on July 23, 2018. The signing of its IRR was on February 14, 2019, just before the UHC law was so too signed. IRR Rule 2 defines the NICC program, the NICC Council, and the Cancer Control Division. The Council first met last May 12, 2021. The Council members include the Secretaries of DOH, who chairs the Council, Secretaries of DILG, DSWD, DOLE, and the heads of FDA and PhilHealth, joined by the non-ex officio members led by Dr. Samuel Ang, Vice Chair of the Council, who is from the Society of Surgical Oncologists Philippines, Dr. May Dolendo, Philippine Society Pediatric Oncology, Dr. Rachel Rosario, Philippine Society, Hospice Palliative Care, Ms. Carmen Oste, Cancer Coalition Philippines, and Dr. Corazon Ngelangel, Philippine Cancer Society. The Council's first act was to agree on the National Cancer Control Strat Plan 2021-2030 and the operations of the Cancer Control Division, so that the foundation of the NICA is now established. The framework of the NICA program and Strat Plan directs itself from its vision, Cancer-Free Philippines, cascading from the UHC Formula 1 Plus for Health, Ambition Natin 2040, and influenced by the UN SDG 2030 Goal 3.4 and the WHO Global Cancer Initiatives. The how leans on the 5 pillars: good governance and sustained financing, equitable access to quality services across the cancer control continuum, strategic partnership and collaborations, robust information systems, technologies, cutting-edge research, capacity building, and institutional strengthening. And the NICA program and Strat Plan champions are multi-sectoral. The NICC program framework is a multi-level system addressing the individual, the healthcare providers, the healthcare organizations, the community, reflecting whole of government, whole of society, health in all policies, and multi-sectoral collaboration. The NICC program covers the processes of care across the cancer control and patient care continuum, noting transitions in care, reflecting life course approach, aiming for quality outcomes. The NICA Strat Plan 2021-2030's mission is people, family, patient-centered healthcare system delivering accessible, equitable, inclusive, quality cancer control services. Its goal states that by 2030, provided cancer control services to at least 50% of all Filipino cancer patients, improving their quality of life and reducing overall mortality from cancer by 10%. NICA IRR Rule 3 revolves around the Philippine network of cancer centers from the DOH designated cancer centers across the country to the Apex Philippine Cancer Center. The Philippine Cancer Center Strat Plan 2021-2030 was presented to the Council last August 13, 2021. The PCC completes the foundation of the NICA, and together with the Council and the Cancer Control Division form the instruments for the implementation of the NICA law. The PCC will be a cancer specialty hospital, particularly for rare cancers and complicated cases, a cancer research center and hub, a facilitating agency for the Philippine Network of Cancer Centers, sharing of expertise, training, research, conferences, patients in a scientific fellowship. Within 2021, therefore, institutionalized the Philippine Network of Cancer Centers with an enabling policy to operationalize mechanisms and processes of shared care network among public and private health facilities for cancer. A shared care network first in UHC priority areas where the cancer centers are located. Equally important is the partnership collaboration with the Philippine College of Surgeons Cancer Commission on multidisciplinary team approach to cancer care, MDT summits, harmonization of CPGs, and competency expertise enhancement in collaboration with other oncology specialty societies and training centers. This is the resource stratified framework locating the relationship of the specialty cancer hospitals, centers, to the community care system. The Philippine Network of Cancer Centers are so defined as the National Specialty Center, which is the Philippine Cancer Center, the Advanced Comprehensive Cancer Centers within the medical centers, particularly in the cities, and the Basic Comprehensive Cancer Centers within regional hospitals, with a graduated service capability and expertise for cancer care. These are the members of Philippine Network of Cancer Centers with Philippine Health Facility Development Plan 2021-2040. PGH is included as per MOA with DOH. Guidelines will be written on inclusion of interested private cancer centers to join the network. This depicts the geographic distribution of the cancer centers across the country, bringing the specialized cancer care nearer to the people who are separated, who reside in islands separated by bodies of water. The NICA IRR 7 defines the supportive environment for the cancer patient, the person living with cancer, and the cancer survivor. So that within 2021, the PWD status of the cancer patients and survivors is official, and their consequences considered by SSS, GSIS, DOLE, civil service, and insurance commissions. NICA IRR Rule 5 and 6 define affordable cancer care and treatment and essential medicines, and included in these are the rules of PhilHealth, Malasakit, DSWD, PCSO, and other sources of funds. So within 2021, issuance by DOH of the following enabling policies and guidelines: AO on Cancer Assistance Fund, AO on the expansion of the Cancer Supportive Palliative Medicine Access Program to cover not only breast and childhood cancers but also other top cancer sites with corresponding ECMAP registry and patient navigation program. And within 2021, the Philippine National Childhood Cancer Control Program would have been approved and disseminated for implementation. NICA IRR Rule 8 defines cancer registry and monitoring system. For the Philippine National Cancer Registry to primarily support the existing Metro Manila population-based cancer registry, the DOH Rizal Medical Center, RCR, and the PCS MCR, and to expand to Luzon population-based cancer registry, Baguio General Hospital, Metro Benguet, and Region 1 Medical Center, Region 1. Visayas population-based cancer registry, Vicente Soto Medical Center, Metro Cebu, and Mindanao population-based cancer registry, Southern Hospital and Medical Center, Metro Davao, in collaboration with WHO IARC with the use of CONREG, so that this registry will be recognized regionally and globally and will be able to speak with registries in the world under WHO IARC and using CONREC. For the population-based cancer registry by geographical site, supported by the Philippine Census and Statistics Bureau, particularly for cancer mortality data, and particularly in the Philippine Network of Cancer Centers, hospital-based cancer registries across these cancer centers, with the Philippine Cancer Center to issue the guidelines for standardization and harmonization of cancer patient medical records datasets, content of hospital-based cancer registry, and establish systems for consolidation, analysis, and storage of all this data. The NICA IRR Role 4 defines cancer awareness and literacy in the public at large, the communities, the schools, colleges, universities, and the workplace. So, a year-round cancer awareness monthly events in collaboration with the DOH Health Promotion Bureau, LGUs, CSOs, patient support groups, and other stakeholders. The DOH Health Promotions Bureau has been doing this campaign for a long time now, covering all the illnesses, the diseases, the conditions under their responsibility. We just have to re-emphasize the messages on cancer control. This is actually part of the universal healthcare, cancer control in the context of UHC, including cancer control measures such as Hep B and HPV vaccination, cancer screening with PhilHealth Consulta and comprehensive outpatient program. The NCC program also gathers strength from the DOH budget allocation for GAA plus Mandanias, National Facility and HR Development Plan, Local Health System Maturity, Capacity Development Curriculum, CPGs, and Health Technology Assessment. And so too, the NCC program depends on all of us here for its implementation. It takes the whole orchestra to play the symphony beautifully. It takes the whole country. Thank you all, and good day.
Thank you, Dr. Ngelangel. If you have any questions to our dear audience, please type them in the chat box and we will discuss them in the live open forum. The second part will be on optimizing strategies for early detection and treatment in breast cancer. This will be a case-based discussion. Again, our panelists, Dr. Michael D. San Juan, Dr. Siti Aneza Camille A. Maglangit, and Dr. Faika T. Bag.
Now for our panelists. Our first panelist is Dr. Michael San Juan, who obtained his Doctor of Medicine degree from the UP College of Medicine in 2009. He did his residency training in internal medicine at the Philippine General Hospital from 2010 to 2012 and served as chief resident of the department in 2013. He did his fellowship in medical oncology in the same institution from 2014 to 2016. He is a clinical associate professor at the UP College of Medicine, an active consultant at the Manila Medical Center Manila, part-time medical specialist 3 at the Department of Health San Lazaro Hospital, and part-time lecturer at the School of Medicine of Centro Escolar University. Our second panelist is Dr. Siti Aneza Camille Maglangit. She obtained her medical degree from the UP College of Medicine in 2009. She did her residency in general surgery from 2013 to 2018 and her fellowship in surgical oncology from 2019 to 2021 at the Philippine General Hospital. She is currently a medical specialist 2 at the Cotabato Regional and Medical Center. Our third panelist is Dr. Faika Bagis. Dr. Bagis is a radiation oncologist who obtained her degree in medicine from the UP College of Medicine in 1997.
She did her residency training in radiology at the Philippine General Hospital from 2000 to 2003. She did her fellowship training in radiation oncology from 2004 to 2005, and her fellowship training in diagnostic radiology, CT, MRI, and ultrasound in 2006, also at the Philippine General Hospital. She has been a full-time active consultant at the Davao Doctors Hospital since 2010, medical specialist 2 at the Southern Philippines Medical Center since 2017, and visiting physician at the Davao Regional Medical Center since 2012.
So to start, I'd like to kick off with a case. So this is a 40-year-old female who consulted the Barangay Health Center inquiring about breast cancer screening options for her. She has no symptoms related to breast cancer and she complies with monthly self-breast exam. She has no known comorbid illnesses and she has good functional capacity. Her family history is pertinent for breast cancer diagnosed in their 50s for both her maternal grandmother and maternal aunt. And she's a non-smoker, she's married with 3 children, and she's premenopausal with regular menses. So some guide questions. What are the current screening recommendations for breast cancer and what is the current practice in our community? So I'd like to invite Dr. Michael San Juan on the virtual stage to discuss the screening recommendations. Dr. San Juan?
We often think that cancer screening is a pretty straightforward recommendation from international guidelines, something that we can apply across the board, from the cities to the province. But we will soon find out that it's a bit more complex than what we usually know back when we were in medical school. The patient in our case seems to be eager to have herself screened for breast cancer, but we often hear this term, cancer screening resistance. And that's a huge portion of our population who are not willing to be screened. France has the latest nationwide study on cancer screening called EDIFICE, and they found out that as high as 18.9% were never screened. 6% of women respondents said they never had a mammogram. We don't have such a nationwide survey on screening resistance in our country. In that study in France, they found out that never screened women have lower mean age, they are unmarried, they have low social professional categories, they are socially vulnerable individuals, and are smokers. And associated with not undergoing screening are social vulnerability and the consideration that the protection provided by a prevention program is ineffective. And the most frequently cited reasons for not undergoing screening are the following. 42% said they don't feel concerned. 36% fear the examination results. 27% said it's because of individual negligence and it's not a priority. And 22% said that they do self-examination. We don't have such a nationwide survey on screening resistance in our country. What we have are pockets of studies from different parts of the country, such as this study on the reasons for late diagnosis with economic factors, non-awareness of the gravity of breast cancer, and the fear of being diagnosed with cancer. And a 1997 study on breast self-examination, women who refuse to be screened are those of higher socioeconomical levels and who attended college, those who had significantly greater income, those often are nulliparous, and less likely to have had 5 or more children. And another study, a clinical trial on clinical breast examination, the reasons for non-compliance are the following: lack of money for transportation, treatment, and medical expenses, indifference, having no time, non-awareness of the gravity of the disease, some spiritual fatalistic attitudes, and the lack of trust in the health system and in one's chances to be cured. This is the straightforward answer to the case: a mammogram. Because mammography was the modality that was shown to reduce mortality in randomized controlled trials. And these are the recommendations by international guidelines that self-examination and clinical examination are actually not recommended, and mammography can start as early as 40 years old. It can be done every 2 years or annually, depending on the recommending guidelines. These international guidelines now are actually evaluating the utility of more advanced technology, such as the MRI and digital tomosynthesis. And the recommendations are actually are to be evaluated. Currently, the internationally recommended screening for breast cancer is your mammogram. But it is important to take note that in high-resource countries, evidence-based guidelines outlining optimal approaches to the early detection of breast cancer has been defined and disseminated, as I have just discussed. But these guidelines are resource neutral, without considering variable resources, distribution deficits, problems in infrastructure and resources, especially in low to middle income countries. They also do not consider implementation costs or provide guidance on how such suboptimal systems can be improved. These guidelines may have limited or suboptimal use in resource-constrained countries. So is it cancer screening resistance, or is there a health disparity? Common misconception is that breast cancer is predominantly a problem of wealthy countries. Breast cancer is an urgent public health problem in high-resource regions and is becoming increasingly an urgent problem in developing countries. But despite significant scientific advances, developing countries face resource constraints that limit the capacity to improve early detection, diagnosis, and even the treatment of the disease. In low and middle income countries, worsened cancer survival is largely because of late disease stage at presentation and diagnosis, which leads to poor outcomes, especially when coupled with limited diagnosis and treatment capacity. In our country, 53% of breast cancers were diagnosed in stages 3 and 4, while less than 2 to 3% of cases were diagnosed in stage 1. BSE, or breast self-examination, is actually not recommended. There's no scientific evidence that it saves lives or enables women to detect breast cancer at earlier stages. But in countries when the mean tumor sizes are above 3 to 4 centimeters and where most women present with stage 3 and 4, like our country, simplified breast self-examination at the individual level may help to raise awareness and decrease the tumor size and stage at diagnosis. But the evidence regarding this approach remains to be produced. In fact, many studies do not recommend this as a public health intervention because evidence suggests harms such as overdetection of benign tumors, unnecessary physician visits, and unnecessary biopsies and other investigations. Clinical breast examination, on the other hand, could be a valid tool for breast cancer screening. The effectiveness at reducing stages at presentation has been demonstrated, and the effectiveness of decreasing mortality has been suggested by simulation studies, but this still needs to be confirmed. It is less sensitive, definitely, than mammography, but less resource demanding and much more cost-effective. Mammography, on the other hand, may have limited use because of the availability. If you look at this table, taken from the report of the Department of Health, Bureau of Health Devices and Technology, it shows that we only have 22.2 mammography units per 1 million women aged 50 to 69 years. And if we compare it with the other countries, ASEAN countries, the Philippines has a low density of mammography equipment, only 13.1 or 1 million, as I have mentioned. And comparing it to the other countries in the ASEAN, that is actually very low. Fee can be limiting. In government hospitals, it can be free if you are classified as Class B, but the price can actually range from 1,500 to as high as 2,700 pesos. In private hospitals, it can even cost more, from 2,000 to 3,000 or even higher. And PhilHealth, in their website under outpatient benefits, there are no breast cancer screening packages available. But I do remember that there was a House bill filed in 2015 requesting PhilHealth to consider covering the diagnostic services for both breast and cervical cancer. But up to this time, I have not actually seen it being implemented. What we have in our country is a breast cancer control program, or the BCCP, which was started by the Philippine government in 1998. And it is a nationwide implementation of an anti-breast cancer scheme involving public information and health education, case finding, and treatment. It is integrated into the community health structure and equipped to control breast cancer in a systematic, sustained manner, which focuses on early detection and treatment and a healthy lifestyle. This is the document that I found regarding this program, but there are many studies published that have cited that the implementation of this program, it was suboptimal. And the absence of a population-based screening program is a barrier to the current diagnosis of breast cancer, because we are depending on an opportunist approach. The World Health Organization guidelines on early detection of cancer distinguish clearly two programmatic approaches: screening, which focuses on detecting cancer in asymptomatic at-risk populations, and also clinical downstaging, or early diagnosis, trying to detect cancer in symptomatic patients at an early stage. There are guidelines that outline programmatic approaches to support key breast health interventions that can be replicated in communities in which resources are limited to support comprehensive and functional breast healthcare programs. One such initiative is the Breast Health Global Initiative that strives to develop guidelines that is evidence-based, economically feasible, and culturally appropriate in nations with limited healthcare resources and with the goal of improving breast cancer outcomes. For example, in that guideline, they can actually stratify a country or area or a region depending on the level of resources. Diagnosis can be allocated depending on the level of your resources, as illustrated here. Specifically for early detection of breast cancer, you can see here that based on the level of resources, there can be specific recommendations, such as clinical history and clinical breast examination for those countries or regions that have basic level of resources, diagnostic breast ultrasound and mammography for those with limited level of resources. And as we go down this table, you will see that more advanced technologies can be applied for screening purposes. For you to see it more clearly, this is the basic and the limited level resource allocation. And this one shows us that an enhanced level of resource, that mammography can be done as a population-based screening. And those regions with maximal resources can even use other imaging technologies that are appropriate for high-risk groups. For example, the use of MRI. There is hope not only in the new cancer law, but also in pockets of initiatives by various groups. In response, for example, to this gap of the delivery of services to promote early cancer detection, UPPGH started, with the help of some donors, to establish the Pink Bands. This is the Mobile Breast Cancer Diagnostic Clinic Program, which is the first in the country that includes breast cancer screening strategies, such as clinical breast examination by your medical and surgical oncologists, health education sessions, and diagnostic procedures. These bands are capable of doing mammography and even biopsies and some basic laboratory. The National Integrated Cancer Control Act has provisions that would promote the development of a more affordable cancer screening strategy, such as the Section 4 of the Implementing Rules and Regulations, Section 12 on the role of the regional cancer centers, and Section 21 on the PhilHealth benefits of cancer. But we are hoping that the NICA, as it is called, will actually help us in our efforts to implement a more effective breast cancer screening strategy. That's all. Thank you for listening.
Thank you, Dr. Michael San Juan, for enlightening us on breast cancer screening. So for the second part, we will have another case. This time, this is a 53-year-old female who consulted for a 1-year history of a gradually enlarging non-tender breast mass. She has no associated bone pains, headaches, shortness of breath, and cough. She has good performance status. She's hypertensive for 3 years with good control and is maintained on amlodipine 5 milligrams once a day. She has no family history of malignancy. She does not smoke. She does not drink. She's married with 5 children. On physical exam, there was a 2x3 cm hard movable mass on the right breast, no palpable axillary nodes, and the rest of the PE findings are unremarkable. Now, for our guide questions, what is the incidence of prevalence of breast cancer in the Philippines? And what are the common signs and symptoms of breast cancer? And if you have a patient with a breast mass, what is now the approach to the patient presenting with the breast mass? So to discuss, I'd like to turn over now the virtual stage to our surgical oncologist, Dr. Maglangi.
Thank you for the warm introduction. Good afternoon, ladies and gentlemen. Now, I'd like to touch a bit on the current epidemiology of breast cancer. Breast cancer has now surpassed lung cancer as the leading cause of global cancer incidence since year 2020, representing almost 12% of all cancer cases. This is according to the latest GloboCan data. However, despite having the highest incidence, breast cancer ranks 5th in cancer mortalities, of which lung cancer remains the most common cause of cancer deaths in 2020. Similarly, in the Philippines, breast cancer is the most commonly diagnosed cancer. It is, however, the second leading cause of cancer deaths, together with liver cancer, following lung cancer. The table on the left shows well-established risk factors for breast cancer. While age remains the most important risk factor, prolonged estrogen exposure as manifested by early age at first menses and late age of menopause is closely linked to breast cancer. The table on the right shows the newer and more recently identified risk factors which consider genetic, hormonal, biological, dietary, behavioral, and environmental factors. We know that breast cancer typically has no symptoms when the tumor is small and most easily treated, which is why screening is important for early detection. The most common physical sign is a painless lump. Sometimes breast cancer spreads to underarm or axillary lymph nodes and causes a lump or swelling even before the original breast mass is large enough to be felt. Less common signs and symptoms include breast pain or heaviness, nipple changes such as spontaneous bloody discharge, and persistent skin changes such as swelling, thickening, or redness of the skin. A self-breast exam can be done by the patient at home, either in standing position while looking at a mirror and checking for signs of breast cancer, as was mentioned, or lying down supine with the arm over the head to allow the breast tissue to spread out evenly over the chest. So the patient uses 2 or 3 fingers with light, moderate, or deep pressures while covering the entire breast and axilla. This may be done in a spoke wheel fashion or using a vertical, horizontal, or circular method, such as in the diagram. Your hormones fluctuate each month during your menstrual cycle, which causes changes in breast tissue. Swelling begins to decrease when your period starts, so the best time to perform a self-breast exam is usually the week after your period ends. A clinical breast exam is done this time by a health professional. It is used along with a screening mammogram to detect early breast cancer. You can also do a bimanual examination of the breasts while the patient is in the sitting position, which is especially useful for women with large pendulous breasts. The breast exam is completed with the patient in a supine position with the arm raised above her head, again with the same techniques I mentioned previously. So when a patient comes to us for a palpable breast mass, we usually request both diagnostic mammography and breast ultrasonography. A diagnostic mammography is tailored to the specific indication for the exam, such as an abnormal screening mammography, findings that require additional imaging, or abnormal clinical findings, including a palpable mass. For women with mammographically dense breast tissue, ultrasound combined with mammography may be more sensitive than mammography alone. Another important use of breast ultrasound is to guide clinicians in doing breast cyst aspiration and core needle biopsy. Image-guided core needle biopsy, usually with an ultrasound, is currently the primary means by which a pathologic diagnosis is made for suspicious abnormalities identified by screening or diagnostic workups. The recent trends away from the fine needle aspiration biopsy, or FNAB, in favor of core needle biopsy can be attributed to the importance of obtaining tumor biomarkers, such as estrogen receptor or HER2/neu, on core needle biopsy samples necessary for hormonal and targeted therapies, respectively. The role for FNAB remains primarily in the evaluation of breast masses with low suspicion for cancer and in resource-constrained settings. Now, the only indications for incisional biopsy would be if a facility lacks the resources to perform a percutaneous biopsy, or if a less invasive procedure fails to diagnose breast cancer that is consistent with the clinical findings. For superficial breast lesions, a skin punch biopsy provides a good histological specimen with minimal scarring and patient discomfort. Among the gaps and challenges identified in the diagnostic approach to breast cancer, especially in low-resource settings, are the following: low cancer literacy and understanding of risk factors associated with breast cancer among the general population, which is why the Breast Cancer Awareness Campaign continues to be one of the forefront programs of our health department. Lack of breast cancer detection resources in primary and secondary care facilities, as well as limited research devoted to awareness and early detection for breast cancer, which can be improved by an all-encompassing and efficient national breast cancer screening program. Lastly, and equally important, is the identified lack of pathologists in the laboratories in the primary and secondary care facilities to actually provide the histopathologic diagnosis of breast cancer. That's all. Thank you.
Thank you, Dr. Aneza Maglangit, for enlightening us on breast cancer. Now that we have a diagnosis of breast cancer, what are the treatment options available for our patients? So we'll be discussing the surgical options, systemic options, and radiation options. So I'd like now to turn over the floor back again to Dr. Aneza Maglangit for the surgical options for breast cancer.
The primary goals of breast cancer surgery are to remove the cancer by mastectomy, or breast conserving surgery, so-called BCS, and determine its stage also through axillary lymph node clearance. With BCS, only cancerous tissue plus a margin of normal tissue is removed. However, BCS is generally not an option in those with high tumor to breast ratio, multiple tumors within the same breast, or inflammatory or locally advanced cancers. Both mastectomy and breast conserving therapy have been shown to be equivalent in terms of patient survival, and the choice of surgical treatment is individualized. So we have to advise patients who desire of BCS that they must be willing to attend post-operative radiotherapy sessions and to undergo surveillance of the treated breast. So who are likely to benefit from the Z package program for breast cancer? The sample checklist on the right shows the qualifications required to be able to enroll to the program. Patients with breast cancer stages 1A to 3A who are candidates for outright modified radical mastectomy are qualified for the Z package, while those who are amenable to BCT, that is BCS with radiation therapy, are not yet qualified based on the current Z package program. That's all. Thank you.
Thank you, Dr. Maglangit. I'd now like to turn over the virtual stage to Dr. Michael Sanuan for the systemic treatment options for patients with breast cancer.
I would like first to emphasize that cancer treatment is a multidisciplinary team effort. We work with other subspecialties, the surgeon, the radiation oncologist, other internal medicine-related areas of oncologic expertise, and supportive care services. And indeed, the systemic treatment has improved a lot from the well-known cytotoxic agents and hormonal drugs to the development of the targeted agents, the biologics, and immunotherapy. This is due, in fact, to the many drug trials targeting the various hallmarks, enabling characteristics and acquired capabilities necessary for tumor growth and progression. Chemotherapy is available for early stages of breast cancer from stage 1 to 3 and can be given before surgery as neoadjuvant chemotherapy to help decrease the size of the tumor, making it easier for the surgeon to operate on. Adjuvant chemotherapy is given after the surgery with the goal of decreasing the risk of recurrence. Palliative chemotherapy is administered to patients with metastatic breast cancer to improve their quality of life, delay progression, and improve overall survival. We have various agents available locally. In the adjuvant or neoadjuvant setting, we have cytotoxic agents such as your anthracyclines, cyclophosphamide, and taxanes. Targeted agents, trastuzumab and pertuzumab. How about the question on access to chemotherapy drugs? As earlier mentioned, our patients can be enrolled to the breast cancer Z benefit package and also the breast cancer medicine access program, BCMAP, available in some of the bigger hospitals in our country. The BCMAP helps improve the cure and survival rates of cancer patients and alleviate the financial hardships in paying for the costly cancer treatment, including chemotherapy. DOH, or the Department of Health, will like to target the most cost-effective and commonly used adjuvant chemotherapy drugs for the various stages of breast cancer in women. BCMAP can cover the cytotoxic agents, doxorubicin, cyclophosphamide, and taxanes. And the past 2 years, trastuzumab, a targeted agent, is also available. Hormonal treatment such as tamoxifen and letrozole can also be availed from this program. They also provide, if necessary, GCSF support, filgrastim, and even antiemetics on the centron. And the National Integrated Cancer Control Act, in its implementing rules and regulations, had mentioned in different sections of the rules and regulations that it would like to establish a cancer assistance fund to cover for the treatment and medications. And also, they would like to implement reforms to support access to essential medicines, health technologies, and even various innovations. And we are hoping that with the implementation in the future, we will have more programs that will make our chemotherapy drugs available to the uh, patients with breast cancer. Thank you.
Thank you, Dr. San Juan. Now, last but not least, of course, radiation treatment options available for our patients with breast cancer. Dr. Bagis.
Good evening. I am Dr. Faika Bagis, a graduate of UPCM class 1997 and a practicing radiation oncologist here in Davao region. It is my honor to be a part of this grand scientific symposium, and I am tasked to share with you the role of radiation therapy in breast cancer. The objectives of my talk is to know when radiation treatment is considered, when is it recommended, what are the types, the techniques of radiation treatment, the process on how to go about it, and its possible side effects. Breast cancer is one of the most common cancers seen in our country, and radiation plays an important role in the management of breast cancers. Furthermore, radiation is also highly effective as a palliative modality. When is radiation therapy considered? Actually, not all women with breast cancer need radiation therapy, but it is generally considered in the following. After a breast conserving surgery for the purpose of killing whatever remaining malignant cells there is so that the cancer does not return. It is also considered after a mastectomy, especially if the tumor is large or when there are many lymph nodes harvested during surgery. Also, it is considered in stage 4 breast cancers where the tumor has reached other parts of the body, causing pain. When tumors are not operable anymore and when it causes severe bleeding, radiotherapy is also considered. The basis or the justification of adding radiation as part of treatment for breast cancer come from several large randomized trials which demonstrated a clinical benefit with the addition of radiotherapy, most especially in patients with high-risk disease who underwent surgery. To mention a few, the British Columbia trials authored by Ragas and published in 2005, the Danish breast cancer trials published in 1997 and 1999, the National Surgical Adjuvant Breast and Bowel Project trials, and the Early Breast Cancer Trialist Collaborative Group trials were the landmark trials which studied the effect of adding radiation therapy as an adjuvant treatment for breast cancer. These trials all concluded that indeed radiation treatment reduces local regional recurrences and improves survival rates. So the next question is, when is radiotherapy really recommended? Basically, we follow the NCCN guidelines, which is the National Comprehensive Cancer Network guidelines. It is recommended for all cases of breast cancer conservation surgery for tumor sizes reaching 5 centimeters in its widest diameter or more, positive axillary lymph nodes harvested during surgery, and if there is a positive or close margin as shown in the final histopathology. Other factors that are in consideration are if the patient is young, if the tumor is of high grade, if there is positive lymphovascular invasion, if there is an inadequate nodal dissection, if there is triple negative receptor status of the patient, and if there is a positive human epidermal growth factor receptor. And also, if there is already invasion to the skin, the nipple, or the pectoralis muscle. So what is radiation treatment really? It is a cancer treatment that uses high doses of radiation to kill cancer cells and shrink tumors. To explain it more, it uses high energy X-rays to destroy microscopic disease that may be left behind after surgery and after chemotherapy. In the bigger slide is an example of a radiation therapy machine called linear accelerator machine. The patient is instructed to lie supine on this flat table with both arms in upward position. The beam of X-ray come out from the head pointed to the area of interest, like the breast, and as shown in the smaller slide. The linear accelerator machine may rotate around your body to reach the target from different directions. The machine makes a buzzing sound. The X-rays are painless, does not hurt, it does not sting, or does not burn when it enters the body. There are many types of radiation therapy used to treat breast cancer and, of course, many other types of cancers. There is the external beam radiation, the one you see on the left of your screen. There is brachytherapy, also known as internal radiation therapy, which is seen in the middle of the screen. And on the right screen is the IORT, or the intraoperative radiation therapy, which is the latest technology being recommended for early breast cancers. External beam radiation is the most common form of radiation therapy. The radiation is delivered by a machine that emits a single high-intensity X-ray beam from several directions. And as I mentioned earlier, the procedure is painless and relatively fast. Brachytherapy, also known as internal radiation therapy, is best exemplified by what we call interstitial brachytherapy, which involves the placement of several catheters in the breast through which radiation sources are strategically placed in and around the tumor site. Radioactive seeds, pellets, tapes, or ribbons are fed into these catheters and left for several minutes or days before being removed. IORT, or intraoperative radiation therapy, is given for early breast cancers where radiation is delivered directly to the tumor or tumor bed during a lumpectomy. This type of therapy is different from the traditional radiotherapies because it is done in the operating theater together with a surgical oncologist. IORT for early breast cancers is a preferred treatment for several reasons. It is a shorter procedure. It is given in a single dose instead of repeatedly over several weeks, and it has fewer side effects compared to EBRT. Post-mastectomy radiation therapy is directed at the chest wall and often include the regional lymph nodes that drain the breast, which are the axilla, the neck, down to the supraclavicular region. The slide on your left screen represents a conventional 2D radiation therapy. This refers to the old technique of radiotherapy where the area to be treated is defined in relation to bony landmarks. The treatment will be planned by a beam shape of simple square or rectangular field. Typical beam arrangements are the two-field or the four-field techniques. Due to the low conformity of these treatments, both the tumor and the adjacent tissues and organs often fall into the same region, receiving uniform doses. Although 2D radiotherapy is now rarely used, it has a role in palliative treatments which use generous margins and where the simplicity of the planning process allows same-day treatment. Today, conventional 2D RT has been largely replaced by a 3D CRT or a 3D dimensional conformal RT. It is an advanced technique that incorporates the use of imaging technologies such as CT or MRI to generate three-dimensional images of a patient's tumor and nearby organs and tissues. The slide you can see to your right is an example of a 3D CRT plan. Tumor is identified and drawn onto each cross-sectional image, creating a reconstructed three-dimensional target volume. The radiation beams are then shaped or conformed to fit tumor volume and to provide shielding to the normal tissues. This technique allows an improved distribution of the dose, but it is still unable to exclude a generous part of normal tissues surrounding the tumor. Intensity modulated radiation therapy, or what we call IMRT, on the other hand, is a more advanced form of 3D CRT. IMRT allows for the radiation dose to conform more precisely to the three-dimensional shape of the tumor, and best of all, it can modulate or control the intensity of the radiation beam in multiple small volumes. Therefore, IMRT allows higher radiation doses to be focused on the tumor while minimizing the dose to the surrounding normal critical structures. Because it is a complex technique, it requires additional planning, longer daily treatment times, and more safety checks before the patient can start the treatment when compared with a conventional radiotherapy. Not shown in this slide are the proton beam therapy and the image-guided radiation therapy. Proton beam uses protons rather than X-rays. A proton is a positively charged particle which at high energy can destroy cancer cells. So when protons are deposited to the target area, there is very little radiation dose beyond the tumor, which limits damage to the nearby healthy tissues. Unlike with X-ray beams, where radiation scattered to the tumor can still happen. Currently, there is no such machine in our country, but the nearest one is found in Singapore, in Japan, and lately in India. Image-guided radiation therapy, or IGRT, on the other hand, refers to the practice of using daily images of each treatment field to confirm patient positioning and make sure the target is in the field. These daily images are compared to the images used to plan treatment. Direct integration of imaging at the linear accelerator enables daily monitoring of patient positioning, tumor position, and alterations in patient anatomy. This permits immediate reaction to changes from the imaging findings at the planning stage. Any imprecision in positioning can be instantly corrected, and anatomical alterations that require modification of the irradiation procedure can be recognized as soon as they occur and the necessary measures are taken. Image-guided RT is available with the high-end radiation therapy machines. So what are the take-homes of this lecture? That radiation therapy improves local control, lower the risk of cancer recurrence and cancer spread, increased overall survival in breast carcinoma. Radiation therapy can help relieve symptoms brought about by the cancer's persistence or progression. The treatment delivery is safe, quick, and painless. And there are different techniques in delivery which are available to choose from. Radiation oncologists are specialists trained to treat cancer with the varied forms of radiation. With that, I would like to say thank you for your attention.
Thank you, Dr. Bagis, and to our speakers, Dr. San Juan, Dr. Maglangit, and Dr. Ngelangel. So please join us again after this for our live Q&A.
Thank you to our panelists. We call back Dr. Arthur Lui as moderator for the open forum. He will be accompanied by Dr. Terence Kua, a member of the Doctors to the Barrios Batch 35.
Good evening. Good evening again, ladies and gentlemen. Thank you again for joining us. I think we should add Dr. Ngelangel on the screen. Do I see her, ma'am, to the organizers? So thank you again, ladies and gentlemen, for your questions. Please type it in the chat box. It's always an honor and a pleasure, especially to be sharing the virtual stage with a mentor, Dr. Ngelangel, and colleagues here tonight. So this is our last session on cancer. Thank you again to our speakers for your lecture. So I'd like to start, Dr. Ngelangel. That was a wonderful lecture. It's very timely. We know cancer care is a specialized care. There was a question now on the chat box about starting a cancer center treatment facility for places that's a little resource limited. Any advice or any things that some of our audience here could take some pointers from you, Dr. Ngelangel?
Actually, there are. Can you hear me?
Yes, we can.
Yeah. Actually, there are two levels of care, and there are two laws. The UHC law will cover the community, and hence it will cover, the barangay, the municipal health, up to the district, to the provincial hospitals. There was a question in the chat box about provincial hospitals. So it's really actually a UHC law which will cover that. Beb Ho, I think, gave you a bird's eye view of what the UHC is all about. In the UHC, basically, much of the money, the syntax, etc., where the money is now, will now get away from DOH to the DILG. And this is where you should kind of lobby your funds for the provincial hospitals, basically, because this is in the UHC law. Now, if you go to the hospital, this is covered by NICA. And hence, you see, I gave you a slide wherein I said the stratified framework, wherein on one hand are the hospitals. That's your basic comprehensive cancer centers to the APEX, which is a Philippine Cancer Center. That's the one covered by NICA. And this is where the money under NICA will go. Now, on the other hand, there is a community thing, and this is where you are provincial. And this is mainly community cancer control activities. So ano ba mga to? Prevention, primary prevention, and secondary prevention. Primary prevention, as you all know, is cancer awareness and literacy campaign, healthy lifestyle, all those things. And then secondary prevention is your screening. Now, the screening is also two groups: a screening where you can do in the community, and a screening wherein you have to do it in the basic comprehensive cancer center. And this is where your mammography will come in. In one of your studies, you said something like, hindi lahat ng Department of Health hospitals mayroon mammography. There is currently under NICA a facility health development plan from 2021 to 2040. It has to be this. We cannot get the fund all at once and build up all at once all the hospitals across the country. It has to be phases. And it's up to 2040, so you kind of think it's kind of far. But we are competing with COVID this time. We have put in monies, but then kinain ng COVID yun eh. And so instead of 2030, we kind of move it to 2040. That's the health facility upgrading of all these centers. This is where your mammography will come in. It's quite kind of expensive. And that's the reason why for the screening part, you also have to, we cannot do it the whole country na mammography. It cannot be. We have to kind of graduate it also. Some communities will do downstaging, and downstaging can be done by breast self-examination and clinical breast examination. There will be some areas in the Philippines which are richer than other areas, and this is where you can find mammography. Okay, so it will be, well, the thing here, it has to be organized, but it can be different kinds of screening screening policies. So that's the only way. Am I answering you?
Yes, of course.
Yeah.
Yeah.
Answering you.
Yeah. Thank you, Dr.
Yeah.
Dr.
There's another question about Cancer Assistance Fund. That Cancer Assistance Fund is twofold also. One is the Cancer and Supportive CSP-MAP, Cancer Supportive Palliative Medicine Access Program. This is originally, even before the law, is called Cancer Medicine Access Program, and this was only in selected hospitals, giving free drugs for early stage, up to stage 3 breast cancer lang, and also selected hospitals with childhood cancer. So dalawa lang yon because the money is really not so much. And in the NICA law, it provided for money. That's why now it's called CSP-MAP. It provided for money for all cancer types, but priority would be non-metastatic cancer. So it provides money for lung medicines. Now this is medicines, okay? Money for lung cancer, money for colorectal cancer, etc. Now, the other part of the Cancer Assistance Fund is a cancer treatment services. It's kind of broad because it includes screening, it includes surgery that might not really fall under the SAFE packages, it includes radiotherapy. The thing with radiotherapy is it has its own PhilHealth case rate, and it is working well. I think the radio-oncologists here. Now, the thing with, well, surgery also has its own case rates. So doon pumapasok yon. The SAFE package, by the way, for breast is not really that much. It's the first SAFE package that was done before, and hence medyo ito yung pilot, 150,000 lang. So where will you get for 150,000? You know, the SAFE package for colorectal cancer is 600,000. So you see, they are learning now. The PhilHealth is learning to come up with packages. Now for the screening, PhilHealth is coming up with screening packages, but yun nga, graduated po tayo because we don't really have that much money. Much of the money supposedly going to NICA is now eaten up by COVID. But hopefully the COVID will go away, so we'll be on track again. Okay, I said so much.
Thank you. It's always nice to listen to Dr. Ngelangel. Dr. Kua, do you have a question?
For that comprehensive answer about the access to cancer care, Dr. Ngelangel. Maybe we should go to the patient side and ask Dr. Bagis about radiation treatment. As a patient, what can I expect to feel while undergoing such procedure? Nakamute pa si Doc.
Yeah. Can you hear me?
Yes, Doc.
Yeah, that's a very good question because every time may darating na pasyente, that is always the first question na kanilang tinatanong, what will I feel if I undergo radiation therapy? So I always explain, in my experience, amongst all of the cancer cases, ang pinakamadaling alagaan, in my personal opinion, are the breast cancer cases because ang kailangan kong alagaan is the skin, no, the region of irradiation. But commonly, ang nag-undergo ng radiation, what they feel is really yung ang lagi nilang kino-complain or sinasabi sa akin is the fatigue. You know, they feel fatigue all the time. Para silang nagtrabaho ng marami, pero actually wala naman silang ginawa. Nagpupunta lang sila for radiation treatment. And then in the morning, parang they're so tamad to wake up. Usually, ganun ang common na feeling ng somebody who is undergoing radiation treatment. As for the short possible acute side effects, usually on breast cancers, we see this is related to the skin, no, reaction. Nandyan yung after, on the first week, walang makikita. On the second week, there goes the slight erythema. Medyo magsasabi sa'yo, mahahapdi-hapdi ng konti. And on the third and the fourth week, there goes yung dry skin, medyo makati naman. And then on the sixth week, sometimes nagbi-blister sila. So usually yan ang acute side effects na nararamdaman ng someone who undergoes radiation, especially in breast cancer. As for the late side effects, usually sa skin always, no? Skin discoloration, nagda-darken, but sinasabi ko naman sa kanila, just give it time. It will go back to its normal color, maybe 2 to 3 months with the help of emollients, no? Hindi yung whitening creams, no? Just emollients. And sometimes, if not all the time naman, patients develop pneumonitis due to radiation. Not all the time. Pero merong mga 1-2 cases that masyadong sensitive that they do develop pneumonitis. So they cough, no? Mga 1 week after ng radiation, even during the radiation, they start coughing. And when you do x-rays, makikita mo merong pneumonitis going on. Actually, those are the most common lang po.
So for the skin, would be the use of emollients and...
Yes.
Okay.
Sometimes if there's already blisters, I try to give them flamazine, sulfa burn ointments, because actually it's radiation, parang burn light din naman yun. And maganda yung flamazine, silver sulfadiazine, because in 1 or 2 days, nagdo-dry up kaagad yung blisters.
So it's similar to radiation burn.
Yes.
Thank you for answering that question. Yeah, so thank you, Dr. Bagis. Now let me just go back a bit. No? So we've talked about some treatment now, but Dr. Ngel earlier talked about the current access that we have for our patients with breast cancer. That's a Z package, BC map, and I think that's something I'd like to ask our panelists here. No, what currently is available? If we can just reiterate the availability, which hospitals, what is included for Z package, BC map. So of course, there's always that concern for chemotherapy, for targeted treatment. These are expensive drugs. What is included? So I'll start with Dr. Aneza. Then Dr. Mike Sanuan, then Dr. Bagis. Dr. Maglangit.
Good evening. Actually, the program is not yet in place in our institution, but since we opening our cancer center soon, then perhaps we will be incorporating the program, especially the Z package in our institution.
Yeah, but surgery is included, right?
Yes.
Yeah, and I think you've mentioned earlier MRM as part of what is included in the package, but BCS is breast conservation surgery is not yet, right?
Right. Actually, that was based on the PGH program, the MRM as included in the Z package. But for in our local institution in Cotabato Regional and Medical Center, it's not yet in place. The program is not yet in place.
And in terms of systemic treatment, Dr. San Juan, I think it's always a concern for our patients. Access to this chemotherapy, trastuzumab in the adjuvant, in the metastatic setting. What current programs do we have right now?
For chemotherapy, we have the Breast Cancer Medicine Access Program. That's the BCMAP. Previously, it only included the traditional cytotoxic agents and the hormonal drugs. But then recently, in the past few years, our patients can now access targeted agent, trastuzumab, and also they can also avail of aside from the trastuzumab, we have the GCSS support, filgrastim, and also antiemetics. Previously, there are only 4 major hospitals. Those were the pilot access sites, but I think through the years, they are now expanding to various hospitals. Our viewers can check the closest government hospital in their area if they have the Breast Cancer Medicine Access Program or BCMAP to avail of free medications.
And Dr. Bagis for the radiation?
For the radiation therapy, in Davao, I can only speak in Davao region. When I started practicing, ang nag-iisang radiotherapy center is a private hospital. So yung Z package, nung nilabas sila, medyo hindi siya applicable sa private institution kasi with the 100,000, yung noong unang labas niya po 100,000 lang yung package. And sa 100,000 na yon, parang hindi kakayanin yung ma-include yung radiation. Sa surgery pa lang po, I think ubos na siya. And what more sa chemo. So pagdating sa radiation, hindi na po talaga siya papasok na sa 100,000. Ang SPMC, ang government facility ng Davao with the radiation facility only started 3 years ago. Nag-open siya 3 to 3 years ago. And so, hindi pa rin well-established yung Z package for breast cancer. For rectal, we do that, di po ba, Doc Louis, Sir Louis? For rectal cancers, we do the Z package. Pero for breast cancers, parang hindi din pa nagagawa.
Yes, Dr. Ngel? Dr. Ngel Angel?
Yeah, okay. As I told you a while ago, the breast cancer safe package is really very small. And because this was the pilot safe package that PhilHealth did. And not really many hospitals went for it. Not even PGH. I don't know if PGH went for it because it was so many hospitals didn't really go for it. But comparing to the colorectal, which is 600,000, madaling maakit mo yung hospital to do the safe package. So it really depends on the hospital if they're going to implement the package or not. Okay. Now, the BCMAP, well, the before the BCMAP, there were only 4 pilot hospital for the BCMAP. And now they're going to expand to, I think, 24 or 26 hospitals. I gave them the list on the slide. And these hospitals will not be on the same plane. Some will be mauna muna sila ma-upgrade, yung iba hindi. Depende also on where they are now. And not all hospitals will be approved for a BCMAP or a CMAP. They have to kind of comply with certain eligibility criteria. The reason why breast conservation treatment, surgery, is not included in a SAY package is because there are few surgeons across the country that are capable of doing breast conservation surgery. And hence, of course, yung gagawin mo na lang para pareho in all hospitals will be MRM. Okay. So the reason why there are reasons why these are so. Okay. Now the SAY package for breast doesn't really include radiotherapy because, as I told you a while ago, radiotherapy has a very good case rate. Okay. And the SAY package for breast will only really cover surgery because there's a BCMAP, a medicine access program for breast. Okay. Yeah.
And this, I think, are all accessible in different cancer centers. I think Davao region is also one of the one of the centers where BCMAP can be accessed by our patients. Dr. Pua, do you have questions for our?
Yes, I have another very relevant question. What is the best diet for cancer patients? Maybe our medical oncologist can answer this question, or anyone.
Fresh. So fresh foods, fresh vegetables. If you want meat, it's fresh meat, not smoked, not salted. Remove the fat. Okay. Don't eat meat every day. It should be moderation. So as long as they're fresh, diet for breast cancer, it's not really that conclusive. It's really not that conclusive. So I'm talking for the general part, diet for all cancers. So the better one really is fresh foods. Okay, fresh foods. And for those na fat, yung mga ganon, in moderation. Okay, so plenty of fluids also.
And always
less processed food. Yeah.
With what Dr. Ngelangel just said. Dr. San Juan, Dr. Bagis, would you like to add anything?
Known risk factors for breast cancer include alcohol use, but it has a very low relative risk. So if you can avoid excessive alcohol intake, and then postmenopausal obesity is also a known risk factor. But it's similar to alcohol use. It has low relative risk. It has less than 2 relative risk, and hence you have to also consider, aside from the food intake, would be your weight, your BMI, and I think that also very much related to what our mentor Dr. Ngelangel mentioned earlier.
Okay, I think it's almost 7:30 now, and before I turn over the floor back to the host, just as the session chair, I'd like to first thank our speakers and my co-moderator, Dr. Pua, and of course our excellent speakers. It's always a pleasure, always an honor to be listening to, at least virtually now, to Dr. Ngelangel, our mentor, and of course to our colleagues here in the Davao region, and of course Dr. San Juan. So thank you again to all our audience. So just allow me to summarize what we have discussed today. We know that a lot has to be done for cancer care in the country. We know cancer care has improved significantly over the past 10 years. It was very timely, very relevant that Dr. Ngel, our professor emeritus from UP College of Medicine, talked about the NICA law. She talked about how to make cancer care accessible, most especially for the underprivileged. This is a very ideal law. Hopefully there will be true implementation to this NICA law. We've talked about multi-sectoral, multi-level involvement. We've talked about the continuum of care for our patients with cancer. That's from prevention, diagnosis, treatment, and even to palliative care. We've talked about access to medicine across the different cancer centers. Later, we had a case-based discussion. We've talked about breast cancer, which is still the most common cancer. It remains to be a treatable cancer and even a curable cancer if detected early. Dr. San Juan started by talking about screening strategies for early detection of breast cancer, the role of mammography. What if in a center that has not enough resources? We've talked about some of the things that we can do. Later, Dr. Maglangit enlightened us on the approach to breast mass, the different biopsy techniques, what can be done in a resource-poor setting, what can be done in a tertiary hospital. These are things that Dr. Maglangit enlightened us to. And later, we've talked about the different treatment options: surgery, MRM, mastectomy, breast conservation surgery. And Dr. San Juan also discussed the role of systemic treatment. And I think we've talked about some of the targeted treatment that we have available for breast cancer. And Dr. Bagis enlightened us with radiation treatment side effects, where we can get them. And these are all very timely, especially in the era of universal healthcare for our country. So again, thank you, ladies and gentlemen. Thank you, Dr. Lincoln Cuba, Dr. Ngel, Dr. Maglangit, Dr. San Juan, and Dr. Bagis. And I'd like now to turn back the virtual stage to our host.
Thank you to our speaker, panelists, and moderators. We will now proceed with the awarding of certificates. We would like to award the Certificate of Appreciation to Dr. Corazon Ngelangel in grateful recognition for her invaluable contribution as speaker in our session entitled NICCA Law during the UP College of Medicine Grand Scientific Symposium. The Certificate of Appreciation is given to Dr. Michael San Juan in grateful recognition for his invaluable contribution as panelist in our session entitled The Big C, Optimizing Strategies for Early Detection during the UP College of Medicine Grand Scientific Symposium. This Certificate of Appreciation is given to Dr. Siti Aneza Camille Maglangit in grateful recognition for her invaluable contribution as panelist in our session entitled The Big C, Optimizing Strategies for Early Detection during the UP College of Medicine Grand Scientific Symposium. This Certificate of Appreciation is given to Dr. Faika Bagis in grateful recognition for her invaluable contribution as panelist in our session entitled The Big C, Optimizing Strategies for Early Detection during the UP College of Medicine Grand Scientific Symposium. We would also like to award the Certificate of Recognition to Drs. Arthur Gregory Lui and Terence Kua for their contribution as moderators for the focus session on cancer prevention given this 23rd day of September 2021, signed by Dr. Maria Assumpta Cecilia R. Serrano, President of the UP Medical Alumni Society Davao Region and overall Chairman of the Organizing Committee, Dr. Teresa Luisa G. Cruz, Director of the Postgraduate Institute of Medicine, Dr. Charlotte M. Chong, Professor and Dean of the UP College of Medicine, and Dr. Lara Teresa Alentahan Aleta, President of the UP Medical Alumni Society. Thank you, doctors. May we now call on Dr. Teresa Cruz, Director of the UPCM Postgraduate Institute of Medicine, for the closing remarks.
Good evening. In the past 3 days, the Grand Scientific Symposium of the University of the Philippines College of Medicine has provided all of us with valuable knowledge and insights on very important issues: universal health care, COVID-19 essentials, the top morbidities in our nation, and threats to our human wellness. We hope that we will all use what we gained from our GSS 2021 experience to continue our best efforts to deliver optimal care to the Filipino people, especially the underserved. As we mark the end of this great event, I wish to convey my heartfelt gratitude and sincere congratulations to the following. Thank you and congratulations to the UP College of Medicine administration, faculty, and staff for the motivation and support, especially to our beloved Dean, Dr. Charlotte Martinez Chong, who even accompanied me to Davao together with then UPMA's President, Dr. Jean Toral, during the initial meeting with our Davao UPCM alumni in 2019. Those were the days pre-pandemic. Thank you and congratulations to the University of the Philippines Medical Alumni Society for the encouragement to request the first official UPMAS alumni chapter, the University of the Philippines Medical Alumni Society, Davao Region, to take care of the Grand Scientific Symposium of the UPCM. Thank you and congratulations to all the GSS 2021 faculty, the speakers, the session chairs and co-chairs, the moderators, and the panelists for your generosity and excellence. Thank you to our generous sponsors from the pharmaceutical industry. Thank you and congratulations to our IT provider and support, the Raxo Group, and Cyril for the hard work and help in all this. Thank you and congratulations to all of us, the participants, for spending your valuable time with us, trusting us to provide you with a worthy educational endeavor. And finally, thank you. My deepest gratitude and enormous congratulations to the members of the University of the Philippines Medical Alumni Society, Davao Region, who comprise the organizing committee of GSS 2021 under the leadership of President Dr. Maria Assumpta Cecilia Rialubit Serrano, the overall chair of the GSS 2021 organizing committee, for all the hard work and dedication that made the GSS 2021 a huge success. Alumni like you who support and love our college provide immense inspiration for all of us in the UPCM. Salamat po ulit ng marami. Mabuhay po tayong lahat and stay safe, everyone.
Thank you, Dr. Cruz. We would like to remind our attendees to answer the evaluation form as part of your attendance. You may find the link in the chat box.
Our grand scientific symposium has officially come to a close. We would like to thank everyone for taking part in this activity, and we hope to see you again in our future events. Stay safe.
Thank you, Dr. Cruz. We would like to remind our attendees to answer the evaluation form as part of your attendance. You may